Yeah. So, welcome all and very good morning to all. I welcome all the participants, respected chairpersons, and respected speakers to this most excited and Zara Hatke webinar of the NSSA series, in which we are about to learn the game changers, which is very, very essentials to learn in the neurosurgery field, which is Hatke to the academic fest. And we have all the legendary speakers and chairpersons from the countries in which we will going to. I'm very excited. We are going to so much to learn for this Zara Hatke topics. So I welcome Ramani sir. Yesterday, sir's birthday was there, so belated happy birthday, Ramani sir. And because of some family issue, he could not join, but he will join soon. Welcome, Dev Pujari sirs. Despite of your health, you presented to us. Thank you so much. We really appreciate, sir, for your presence. Respected Salwan sir, our NSSA current president, Dr. Batuk Diora, our NSSA secretary, we are welcoming you. All the respected chairperson, Dr. Sridhar, Sumit sir, Dr. Sachin, Dugani sir, Paritosh Pandey is also joining. Our legendary Goyal sir is our today's he is a Sachin Tendulkar. He is opening our this live match and 2,205 at present registered participant is with live with us, and that is a great thing. You all are excited for that. Welcome, Manjul. So now, welcome. I would like to welcome Dr. Apurva. He is our moderator for today. Rishabh, our co-coordinator. So over to you, Dev Pujari sir. Welcome you, and let's start the show.
Thanks, Jayesh, Apurva. Belated happy birthday to Ramani sir. And we get this program started. I think it's a unique program in the sense that we are talking of several game changers. And we have some of the people who have actually changed the game in neurosurgery. And first and foremost, waiting in the waiting lounge is our Professor Dr. Atul Goyal. I think this is the appropriate talk for him for today because he's the most prolific writer not only in India but I think one of the best in the world. And I think he has influenced a lot of his contemporaries and younger colleagues to look at this part of their career very, very significantly. And without further ado, I think I would request Dr. Professor Atul Goyal, who's currently now chief of several hospitals, including Somaya and Lilavati, apart from being a colleague of mine at Bombay Hospital, to start his talk, please.
Thank you, Shekhar, for that introduction. Can you hear me, Shekhar?
Yeah.
So, it is, I thank NSSA, Professor Ramani, and all the organizers to organize such a different kind of webinar. And to talk on publications in neurosurgery is absolutely a contemporary subject, an important subject, and futuristic subject. Now, if I say publications are important, this is everybody knows, of course, publications are important. But publications are extremely important. Publications are not ordinary. Publication is going beyond a line. If we publish, we achieve. The well-known saying is publish or perish. Of course, this is important. We are good neurosurgeons. We are fantastic neurosurgeons. But if we want to certainly go beyond a line, we want to make a mark, we have to publish. And publications are an outcome of your thought process. You don't have to be extremely intelligent or extremely good in your English or extremely, I will say, even if you are not extremely good in neurosurgery, but your thinking process, your thought process, if there is something innovative, something different, something novel, that is what will matter and is what is going to count. Writing is not I am a good Englishman, so I can write. What for neurosurgery, what you have to do is, one is aspire to become a good neurosurgeon. by operating, understanding, studying, and all those things. Then you have to aspire to become a better neurosurgeon. That also by working in the operation theater and going on working in the operation theater. I sometimes like to say, enjoy the smell of the operation theater. Enjoy the smell of cadaveric dissection and anatomy lab. Enjoy the beauty of dissection. Then you have to become the best neurosurgeon by continuously working, and that also will come by going on operating. But if you wish to go beyond a line, if you want to go beyond borders, you have to publish. And publication is not an ordinary thing. Okay, I want to publish, so I publish. Oh, I want to, do more than what I am doing. I want to publish. It is not like that. It is, you have to get a new idea. You have to get a novel thought. You have to understand the things differently. And if you have a thought, if you think that whatever you have thought is different from what others have been thinking about, if you want to relay what you have experienced, which is you think is what others have not experienced, if you think that your case volume and your case material, others can learn from your volume and case material, then only there is a point in publication. You cannot say, I have got so many numbers, I have got that many numbers, and I am good, and I am. Every publication is an outcome of a novel thought. Every publication is an outcome of a new idea. Every publication is an outcome of absolutely contributory effect. If you think your publication can be contributory, then you write. If you think your publication has the power to direct and change what is existing and can contribute to the growth of what is the subject, then only you should write. And when you write, one thing I have learned and one thing I have understood, that idea, does not always come from the senior most in the department. Ideas can come from junior most in the department. And I have no hesitation to say that many of the articles that I have written and many of the thought process that I have gone through have been contributed in some way or the other by my juniors. So here and there they have talked, and here and there they have told me whatever they have told me. And so never underestimate a junior. Second thing I will like the juniors to know is, never underestimate your own self. Don't think that you cannot get a new idea. And also when you are operating or when you are seeing some operation, and if you think, no, I would have done a little bit differently, or maybe I would have done this stitch little bit differently, or maybe I would have done this closure differently, this tumor resection differently. Don't underestimate that this different idea that you are getting or different thought you are getting is useless and may not be important and all those things. What I used to do earlier in my career is, whenever I thought that this was a new idea, I used to go to the computer. That time there was no internet, but we used to have floppies. And those floppies contained all the PubMed articles in the world. And through those floppies, we used to extract the publications. And many a times when I thought it was a new idea, it would have already been published 100 times before. So new idea is one thing. New idea is what changes the world. New idea cannot ever be underestimated. It may be a foolish idea. It may be a useless appearing idea, but idea is an idea. One idea, little idea, is bigger than 1,000 people operating for 1,000 years. This is what my professor, Dr. Kothari, used to say. And we have to continue with our thought process when we are operating. We are not just technicians, we are surgeons. We are dealing with patients' lives. We are thinking, we are performing. This is a performing art. Whilst you're dancing on the stage, that is performing. Neurosurgery is like performing on the stage. So you have to, when you are performing, sometimes you get a new kind of a thought. So you have to be a good neurosurgeon for the patient, by the patient, and always, no publication can be where there is no thought for the patient. And my feeling is if Indian neurosurgery has to progress, we have to continue writing in a bigger way, because what I see today is that countries like China are maybe probably they are having the potential to overtake us. Because see their publications, all the journals are flooded with Chinese publications. All the journals have been historically flooded with American publications. And also, I must also tell you, maybe your idea is great, maybe your idea is tremendous. Indian, for Indians to make a mark in the international field, international arena is not easy, because there is an academic apartheid. Your contribution may be tremendous, but recognition of that tremendous achievement or contribution is not so easy from India. So you have to learn to accept that kind of thing. What my message for young and senior and every neurosurgeon is, if you have a thought, don't underestimate a thought. You can write only if you have a new thought. You can write and contribute only if you think that your contribution is going to be contributory. You can write and achieve no matter what. If you want to achieve more than usual, if you want to go farther than what you are expecting, you have to write. So there is appeal or urgent appeal to all my fellow juniors and seniors and everyone, that we cannot underestimate the art of writing and art of thinking, and that thought process ultimately culminates into a publication. You please do that, and my best wishes to all of you. Thank you very much.
Thanks, Atul. I think that was very, very inspiring. Uh, Rather than the mechanics of scientific writing, I think you have focused on the philosophy, which is extremely important. And I think uh, as you become senior, philosophy takes a larger part of your thought process. So that is quite. There are no specific questions related to the this talk, but there is one very basic question asked by a young neurosurgeon as to what is better to join academic practice or to join corporate practice. There are, of course, other types of practice as well, but this is not within the scope of this current talk. However, I would like you to say something that do you think now that you are out of a major educational institution, you will still continue to be as prolific in writing? And do you think that you still believe that your new experiences should be shared with people?
You know what, Shekhar? I have been writing all my life. Number of my publication is very proudly, I say, and not to showcase my work, but to influence. If somebody can get influenced, is 786 on PubMed. And I can also tell you, I become happy when I operate, and I am become very happy when I do a very complex operation and the result is beautiful. There is no question, that is our life. But I must also tell you, the greatest happiness I get is when I get a message that your paper has been accepted. And this is, in 1996, I got a message from Acta Neurochirurgica that I had sent several papers at that time. On one day, I got 4 papers got accepted. And, that day of mine has been the happiest day of my life. I cannot tell you how my happiness. So every time I receive a message from the publisher or from the editor that yes, this paper is accepted, there is believe me, that happiness is beyond words. So I want everyone to experience that happiness. And that happiness will come if, your publication has a reasonable strength. And you have to, there are various ways of publishing. You can write articles, you can write case reports. Even you have to begin with case report. Even when you write a case report, there has to be some beautiful message in that case report. So look for the message, look for a new kind of a thought process, and then only you can write. And that when that thought process gets accepted by a journal, there's no happiness more than that. And I'll promise you, my dear Shekhar, that I will not only continue writing, my writing spree will absolutely maybe probably increase in the next coming few years. And I am doing the work which I am doing and I am happily doing. And I think there are several new thoughts in my mind that still keep on cropping in here and there. And if the day when I stop thinking about new thoughts and stop thinking when I am operating, I think that will be a very sad day for me and for my life.
I think very, very nicely said. Dr. Selvam, would you like to make any comments or ask any
just one
questions?
thing, sir, before the stalwarts catch up with their flight. All the stalwarts are here. The future stalwarts are also, sir, I am saying. Why don't we think of a national registry, which we are lacking now? You people have to work together and find out a source, how to start. Little bit of deviation from the present discussion, but I want to convey it to especially Atul Goyal, Sridhar and all, when they are still on the run. We should have a thought process to develop a national registry at least. Linking at least some districts or some states.
You know what, Dr. Selvan, I'll tell you about national registry. National registries are very important. If you see the current trend of articles, many of the articles I get to review, there is a huge database in America in particular.
Even in China.
Like in spine, I recently reviewed one article where they were reviewing complications after 10,000 spine surgery, lumbar spine surgery, 10,000. What they had done is entire American thing they had compiled and they were talking about complications. So it is important, but I think it is not it is probably a very distant dream as far as Indian context is concerned. We have to make a registry for brain tumors. We have to make a registry for gliomas. There has been some effort in Tata Hospital where I am coordinating their little bit effort in getting a registry made. Neuro-Oncology Society, there is a big move about making a kind of a tumor registry made. But I think it is quite in the infancy and long time efforts because there is not so much motivation to anyone or everyone to contribute and they get some benefit out of it. There is not such motivation. I hope when this comes, probably the registries will come. I think Sridhar may address it better than what I can say about this, Selvan.
Thank you, sir.
Jayesh sir, any comment?
So I think it's a necessary.
One question I wanted to ask Professor Goyal, sir. How is the McDonald burger on Sunday morning?
McDonald, you know what? I am on the airport. They have put the board that my boarding has started. I can still take 10 minutes to listen to all my friends and all my colleagues and I like to call my colleagues, Suresh, fellow travelers. Travelers.
True.
What do you think of this word, fellow travelers?
True.
We are all traveling towards a destination and we are traveling in the same kind of a compartment of train.
Yeah.
We are maybe having first class seat or third class seat or reserved class seat or unreserved seat or whatever. But we are traveling in the same compartment towards the same destination. And that destination of our life is the welfare of our patients.
Absolutely.
And that beauty that we have been blessed with.
Absolutely. I agree with you.
And the opportunity that God has given us to treat our patients well, I think that opportunity we have to make use of and we have to continue our travel with happiness. And
Absolutely.
While we are traveling, we should talk to our fellow travelers and laugh and enjoy. I think that is our journey will make us more beautiful.
Thank you. Sorry, nice.
So I think we need to get the next traveler in before his flight is ready to depart. And that is Professor Sridhar. So
Thanks. I'll just share my screen.
Sridhar currently is the chief at the Kaveri Hospital, and where he has started a new neurosurgical unit, and secretary of the Neurological Society of India. And I'm sure we are all going to listen to him about the managing complications in practice, which is an important aspect. Please go ahead.
So you can see my screen, please?
Yeah.
Okay. So,
but go on the, right.
Yeah. So thank you very much to NSSA and the leadership and Jayesh and all the others. And thank you for accommodating me because of my flight. So I'm going to start with a small story of a 40-year-old lady who came to us with imbalance. And as you can see, it is a fairly straightforward posterior post-arterial based meningioma, some hydrocephalus. So we operated on her. We had initially started with a EVD to relax the cerebellum, and then the tumor came out, no problem. But the patient woke up with a left hemiparesis. Now the reason for the left hemiparesis, what is marked here, you can see the EVD has gone right through the capsule. These are complications which we don't want ever, but often happen. All of us carry with us our own suitcase of complications. And as Michael Lawton said in his quote, complications are unavoidable, and the only way to avoid complications is not to operate, which none of us want. We all want to continue operating. Many of the best surgeons take on the hardest cases, so they encounter more complications. The two main types of complications, if you see, one is bad luck, which you can't do anything about, it just happens, and the other one are preventable complications. And therefore, what you see in the most common types of complications most often are an increase in neurological deficit. It can be because of a postoperative bleed. It can be because of seizures. There are many other wound-related and other complications that you would definitely face at some point or the other in your professional life. People have classified these complications basically as an audit of how your own complication rate is. And that is something which I think all of us need to do to actually know how we are doing so that we can truthfully talk to our patients about it. But the question is, when there is a complication, what should be done? I think this starts well before the surgery. It starts in the outpatient with counseling and explaining, and more importantly, documentation. So documentation starts right from the outpatient. We must spend enough time explaining the surgical rationale and expectations. We must answer all questions in a very personal way and not get upset or agitated if Google is thrown onto our table. We should also avoid boasting and avoid an overconfidence. And most important, I think, inform your experience in that particular type of surgery to the patient and their attendants. I think what is important, other than quoting literature, is also your experience and your risks and complication rates. It's also important to try and explain medical issues with visuals. Avoid jargon so that the patients and their attenders understand what you're trying to do and what you're trying to say. Explain and ask for questions and clarifications a second time. Normally, I do it the evening before the surgery because sometimes the first time you explain things, it doesn't really enter their brain and mind. So the second time you ask them, they may be having more questions and more clarifications that you would have to answer. When there are high-risk surgeries and other situations where you think that the patient's relative may become belligerent, especially in the patient is critical in trauma or other situations, video counseling is also a good thing to have so that you have a proper record of the fact that you have actually counseled the patient. Now, it is very important, and this is medico-legally, we have heard this from experts time and again, that in the OPD as well, you must put down all your recommendations. Whatever it is, if you cannot be forced to say something by the patient's relatives just because they want something. What you are giving is your medical expert opinion to the patient, and that cannot be changed for the sake of the patient. So you must write that recovery will take time. You must write that rehabilitation is necessary. The patient will never become all right the next day after surgery. So these are all things which you must put down on paper, as well as an estimate of the risk that you think the surgery has. But very, very important is documentation of the informed consent. Now, if you look at this, the current guidelines on consent taking must have the following. For example, the doctor's name. What is the procedure's name? What is the diagnosis? What is a brief description of the procedure, benefits, what will happen if this procedure is not done? What are the complications of the procedure? And what are the alternatives to the current procedure that you are suggesting? These are all now legally mandated to be there in an informed consent. You must also have a page where you have the opportunity for a patient representative to sign separately if the patient is not in a position to give consent. You must also have provision for an interpreter if the language that you speak is not understood by the patient and their relatives, and as well as an additional consent, for example, to take out some tissue if you have to take out to have observers inside to do videography and things like that. But I think the most important part of this consent process is to have a blank page where the surgeon or the surgical team must write down just before surgery what are all the risks and complications and procedures that this particular surgery has. And this is, I think, the most important thing. So if there is a complication, how do we and what do we tell the patient and the family? Now, this is a very, very interesting article which is there written by Marcos in the CNS Journal Neurosurgery. And there is a podcast also which you can listen to. I think all of us as surgeons who have and are seeing complications must go through this article because it beautifully put down words about how to deal with complications. So the most important thing is how do you communicate bad news? There are some recommendations like the 6-step spikes model, which is there. But I think the most important thing are these 6 points. One must be truthful. One must avoid distractions. Do not evade difficult questions. Maintain composure. Sometimes the relatives might get aggressive. They might not believe in you. Their attitude may be wrong, but you must maintain composure at this point of time. Listen to all that they have to rant because they are grieving sometimes. They are anxious, but listen. And then offer help in whatever way possible and explain to them what you are planning to do step by step for the recovery of the patient. It is very important in these situations not to be a turtle or an ostrich. Do not retreat into your shell, nor should you bury your head in the sand. Like Marcos said in this article, the human impulse makes us withdraw from unpleasant situations. But this is the time when you do your visits, you must actually visit twice or thrice. The patient who does well, it does not matter if you miss a consult or if you miss a visit. But a patient who is not doing well, you have to visit at least 3 to 4 times a day because relatives want to see you there, want to understand that you are looking after their patient and that you are not forgotten the patient or you're not running away. We have to spend the time effectively. We must be sincere in our empathy. We must be sincere in our efforts to find a solution. And we should not be defending ourselves or evading the blame of a particular complication. So we must actually sit with people and talk to them more and more from our hearts. So what they need is old-fashioned honesty, transparency, and compassion. Now, how do you communicate? Avoid speaking down. Never look down upon them as though they are inferior. Some of the non-verbal communication skills is your body language. And therefore, try to sit in the same level and height so that you give the patient a feeling that you are connected with them and they are connected with you. Also, posture. Leaning forwards gives the impression that you are attentive. And never have your phone ring and pick up your phone in the middle of a conversation with a patient who's having a complication. So put your phone and other distractions away. And finally, you must dress to inspire confidence. I know some modern movies, have surgeons in a very bizarre dress sense. But then this brings out James Osman editorial in 1996 is How You Look Important, where he says that if you look like a professional, talk like a professional, and conduct yourself like a professional, you will go a long way in convincing your patients that they can rely on you as a surgeon. Bad outcomes coupled with a poor professional attitude and poor appearance only reinforce the impression that you are not a competent neurosurgeon. So dress is important. One must look professional. Most important, if there is a complication, review documentation immediately. Have a lawyer on hand because one must keep calm and be prepared. While you deal with the problem of the complication, please make sure that you are prepared for any eventuality or a medical legal case against you. So start the documentation from the day the complication happens and make sure that you are safe. I found this quote from Keki Turel, who's been championing complications and looking at complications, where he ends with this quote, have trust in yourself and faith in your beliefs. So thank you very much for the opportunity, and I welcome all of you to this international update in February. Thank you.
Thank you, Professor Sridhar. If I may, I have 4 questions, if you would be kind enough to answer them. So the first thing is, am I audible? Yeah.
Yes.
So the first question
Sorry, but
is,
there is an announcement going on. I mean,
I know, sir. So the first question is that when a complication happens, which obviously we all have in our practice, and obviously, as you said, that we do a preoperative counseling maybe once, twice, as much as required. But after the unwanted event happens, on the next days, consequently, the number of relatives keep on increasing. And we have to go through the same explanation which we have gone before the surgery to relatives whom we have never seen or heard of. And at one point of time, it becomes a bit frustrating. So how do you handle that, sir? That is the first question.
You have to keep going on. Now, there will be, the number of relatives, the new relatives, they increase because the patient's attenders are anxious and therefore they reach out to their circle. So they come in for giving support. Sometimes it is a positive support. Sometimes you find that there are attenders there who are there just to show the patient's family that, मैं भी जानता हूँ, मैं भी करता हूँ.
Yeah, yes.
I mean, that attitude. But if you are confident that you have done nothing wrong, or this is a complication which can happen, and you are managing the complication, and that you are sorry about the complication, but you're not saying I'm guilty, do me in and things like that. I think you have to have the confidence to look them in the face and say, this is a complication. This is a major surgery. Complications can happen. This has been explained even earlier. And we are sorry, but we are handling the complication and we are with you to help you. I think we have to do it again and again. There is no way out. The minute you start running away, that's when the problems come. Second thing, what I sometimes do is I tell the patient's immediate family with whom I have been connected from before the surgery that come with just 5 people if you want. Come with your immediate family whom you want for support. Then you communicate to the rest of the group. Because for me to talk to new people again and again, I will not be able to give my time to other patients who also need my time. So this is something I appeal to them rather than pushing them away in a wrong or bad way. So patients, attenders often understand this and they cooperate in that way. So that's how I tackle that situation.
Thank you, sir. So the second question is, obviously in private practice, when we have such an event, the prolonged ICU stay and the newer interventions and the investigations lead to an increase in the cost of the patient in total. So there's always a pressure on the operating surgeon to reduce the surgical charges. So do you think this should be done, or do you support this kind of a issue when, the patient has already not improved, maybe has gone into a prolonged ventilatory or an ICU stay? Should the surgeon's charges be reduced? Does it portray the guilt of the surgeon, or should it not be reduced?
Nothing should be done immediately. Point number one. You are trying to help the patient to the best of your ability. Now, one thing which I have done most of my life, neurosurgical life, is I never talk money to the patient. I have my team who are the people who always talk money, whether it's a simple lumbar disc, sebaceous cyst, or a skull-based surgery. The money part is always spoken by somebody else. At the end of the day, we are medical experts. We should not become businessmen. So that is something which I very strongly believe in. And in my department, over the last 20, 25 years, no money is spoken by any of us to the patient's attenders. We listen to their problems. Now, suppose there is a complication, definitely costs go up. Patient has to be on ventilator, patient has another procedure. So the financial counseling is done by the separate team. Definitely patients and their attenders will come back to us and say that, we are running out of money. So you say, we will try to help you. But you never tell them, oh, my fees I will take away. Never do that, because that is something which you should not do. You're not charging, you're charging for your professional, what you have done professionally. Now, sometimes when there is an absolute need, you can reduce or give a discount. This is my fees, I am charging you, but then I'm giving you a discount, recognizing your thing only when they ask for it, not without their asking. Okay? And then you can also talk to the management to give discounts, but I think you yourself should not offer first hand saying, I will reduce my fees. No, never.
Sumit sir?
Yeah, I think, this is a very valid point raised by Dr. Apurva. Financial, this thing, being a doctor, being an operating surgeon, as very rightly pointed out by Dr. Srini. Generally, I have never spoken to the patient regarding the money aspect. That is for the hospital part and my team to deal with all these money problems. No, you are there simply to give advice, to medical advice and the surgical advice and the surgical treatment to your patient. Always remember, never talk money with the patient, because the moment we do that, he expects the same conversation in the future also with you regarding all the money aspects. Now, this is this aspect. And if suppose if the patient you had operated on has a complication, and what will you do about the discounts and all? We don't generally discuss these discounts with the patient. It is up to the hospital and the management, and my team will look after the discounts. And yes, certainly we do that if we see that patient is having prolonged ventilatory support, prolonged stay in the hospital, crossing his financial expenditures. Yes, we of course have to certainly do that just to humanly help the patient. But my preference would be that the patient does not know that I have done this discount for him, because the moment he knows, you are on a weaker point. legally also and in his mind also that you have done the discount simply because you are afraid that he will take any legal action against you. So never let the patient know that you have made the discount, even if you want to make a discount, even if you have done the discount to the patient.
Thank you, sir. Dr. Devpujari and Dr. Salvat, do I have time to go ahead with the questions or do we go to the next speaker?
I would like to push one question if time allows.
Okay, last question to Rishabh.
Yes,
Yeah.
yes, thank you, sir. Sridhar, sir, very crisp presentation. We've spoken a lot on this platform related to how we safeguard as a neurosurgeon and the patient, right? I would like to chip in one question. What do you think about the indemnity bond, the personal indemnity bonds? Do personal indemnity bonds only relate to the private practicing neurosurgeon or even the government neurosurgeon? And what are the specific pointers that we need to look out related to the legal support and the other support such as social media right now, where defamation is one of the challenges which neurosurgeons are facing or in general the practitioners are facing. How should we go about with the personal indemnity bonds and how do we safeguard from social media defamation?
I will take your last question first. If you put yourself out there on social media, be ready to receive accolades and brickbats. You can't do anything about it. Okay? My suggestion, don't get too flustered. Have an equanimity and be ready to accept that people who don't like you or have had a problem because of your treatment are going to say something bad about it. Okay? So you have to, you can't do anything about it. Okay? What you could do, this is a advice, try to bury that comment with a lot of good comments so that it doesn't pop up. Okay. Now, as far as indemnity is concerned, I feel the minute you qualify as an MBBS doctor, you have to have indemnity because it is very, very important in your life because you don't know who is going to sue you and when. Definitely in private practice, you have to have indemnity. There are certain areas in government practice where they are covered and certain which are not covered. Now, I'm not sure of that detail. I mean, there are people like Manjul and Sachin here who I can see. I can't see the others who will know more about whether the government doctors are covered or not. But I think for people in practice, please get indemnity. I mean, the professional indemnity is not very high for even say 2 crores or so. So it is, I think it is worth the effort. Point number 2 is now you have got agencies like NSSA is now tied up with Cover You, which also provide lawyer support immediately.
Yes.
That is point number 2. So I think there are these third parties who help you with that. Otherwise, please also have a lawyer at hand whom you can approach easily anytime there is a problem. Third is NSI also provides the legal cell support. So we have had issues where our colleagues have had a problem, and what happens is we provide an expert opinion which the neurosurgeon can use whenever in court if needed. It's a weapon you have in your hand which your lawyer can use. So I think these are all options which neurosurgeons must be aware of, and you must be prepared. I mean, that's what my last slide was. Be prepared, because it's no point once things happen, then you hurry around, then it's too late. You must be ready. If there is a complication, you have to start from the next day to review your documentation, including your OPD documentation, your operation notes, very, very important, your operative video, very, very important. So you must have everything ready and, and kept so that you have no problem.
Thank you, sir. Thank you very much.
Thanks. We move on to the Dr. Selvan. Any comment?
No, sir. It's a very ideally he covered the important aspects of that, but it's a wide topic to be discussed. A lot of notes will be there. We'll go ahead with the next topic, sir.
Thank you, and I will just leave because I have to board now. Thank you.
Thank you.
Sir, happy journey.
So we move on to Professor Borkar from All India Institute, New Delhi. Uh, Dr. Borkar is here already? Right.
Yes.
Yes, sir.
So maybe you can share your talk, Dr. Sachin Borkar.
Yes. Thank you so much, NSSA, for this kind invite. And my slides are visible?
Yeah.
Yes, but
Yes,
it is
sir.
Taj Mahal introduction.
Yes. So my topic is how to make an effective presentation. And this is one example. This is the ad from tourism department showing come visit the Taj Mahal. It's a very beautiful tomb of a queen. Thousands of artists have worked over it and all those things. So many things about Taj Mahal in detail. And this is the ad from the tourism department. And compared to this is just a beautiful picture of Taj Mahal and just a two-line come visit. So probably the second slide will make many visitors come to and visit Taj Mahal indeed. So that is the importance of presentation. So presentation, does it really matter? Yes, it does matter. And that is the talk of this talk for today. I have no disclosures, only acknowledgements of too many effective speakers, academic as well as non-academic, whom I look forward to listen to anytime I see them in the program. And I have incorporated some of their tips over years in my presentation style. And some of the slides here are shared by my good friend Dr. Bal Murli, neurosurgeon from Chennai. Those are the only acknowledgements I have. So every presentation is an opportunity to make a difference. So if you get a presentation opportunity, you should try to do it well to make a difference. So how to plan? There are 6 helpers which can help you make an effective presentation. And what are those? So who are you talking to? What is your target audience? What is the topic? Why are you presenting this? Where are you presenting? When are you presenting? And how are you presenting? So the usual W's. So who is important? Your target audience. If you are talking to MBBS students, a neurosurgical topic, and an expert audience, all professors sitting in the audience. So it will be a different presentation and not the same presentation which you will give to an MBBS guy. So knowing your audience does make a lot of difference. What is their baseline knowledge? What are their expectations from this talk? Everything should be factored in before making a presentation. So this novice or expert oblique mixed audience, different levels of seniority. Conferences usually have this mixed audience. So it should cater to everyone in the audience. Secondly, what are you going to tell? What is the objective of your presentation and what you want to communicate to your audience is also important. Then why are you making this presentation with? What is the purpose? What you want to educate, you want to convince them, you have to train them. It is also crucial. Then where are you having it? Is it in a closed room, a small room, a large auditorium, or it's online? Everything matters because then there you can tweak some of the settings so that to make it effective. Again, when is it happening? Is it happening post lunch, immediately postprandial hypoglycemia, and people are sleeping? Something like that. So you should also factor in when with the presentation happening and house of technical and non-technical things, whether it will work, the video will work or not. All this you have to check. So coming to the how to structure a presentation, it's usually a 6-step framework. First, you should decide what is your learning outcome. So learning objective, what do you want the learners to know at the end of your lecture? So first decide that, and it should be 1 or 2 learning points and not the entire 10 learning points. Step 2, you have to create a take home message. Rather than first the content, you should create that I want to tell this to take home message to your audience, and that's enough. And because what learners hear last, they will remember. So this end slide is pretty important. Third is design a structure. It should be a set dialogue and closure format. So it should have opening, middle, and end. So opening is pretty important. What do you
first show, a first word, a first sentence, a first picture can hook your audience. This hook is very important. And as per various studies of adult learning, if there are only, you have only up to 10 to 20 seconds to hook your audience. If you cannot hook them within the first 20 seconds, then probably they are gone to their smartphones, WhatsApp, Facebook, and your talk is not attentively listened to. So you have to hook your audience. There are various ways you can hook it. You can make how to make it interesting. You can start with a story, a personal anecdote, any shocking fact or figure, which I showed, like this is an ad of Taj Mahal. So that probably enthused people gave in a neurosurgical presentation how a Taj Mahal came. So probably that brought many people to attention to my talk. Then curiosity, anything what the people may not be knowing, any famous quotation, you can start with some of this, or you can start outrightly with a question or a poll or a raise of hand, and that can actually involve the audience early in your presentation. Second is middle, the content part. It should have 3 to 5 learning points, not should not try to cover everything in one presentation. Content is the key, and you should do a thorough literature search and should be confident of the topic. You should have the thorough knowledge of the topic, and you should also be receptible to the audience feedback, even if it's midway. So you should not shut the audience down just because they have started and a student asks you a question in the middle of the presentation. So receptibility is also important, and end is pretty important. Take home message, and it should not be vague. It should be tangible and actionable. 2 or 3 take home messages are enough for a 10-minute lecture. The fourth step is to edit it and be ruthless in cutting, chopping what is not necessary, just throw and dispose of. Remember that less is more. Then prepare resources if you plan to have some handouts to be given prior to your presentation so that people already know what you're going to talk. That helps and is usually done in educational courses rather than conferences, but that's a pretty important way of involving people. And the most important is practice. So what you feel you're talking great may not be pursued by the audience. So practice in front of a small audience, your department maybe to start with, or you can even practice in front of the mirror for your timing and how you are sounding, how you are looking, how are your gestures, everything. Then the presentation design, the key component are the background, color, text, and images. And as a general rule, there should not be more than 15 slides for a 20-minute lecture. This is what is said, but we usually have more than that. But it should be reasonable, which you should. So basically, 2 slides per minute are enough, not more than that. No more than 6 lines of 6 words per slide. So if you are jacking up with so many things in one slide, that's not appropriate. And use pictures, because picture has a visual memory and it depends. It's more thought provoking than just text. So visual are more powerful. So if you want to communicate this, that 2.3 million women are diagnosed with breast cancer and there are this much deaths globally, it's better to have a picture which just gives the same message that 1 in 8 patient women will be diagnosed with breast cancer, and it's more effective. Other things are slide after slide, bullet points are very boring and it's very monotonous. So break the monotony, have some video, have some picture midway which is relevant. Use charts and illustrations to show what you are saying rather than just reading the text. Use illustrations to make your messages stick to the audience. Like you have to maybe have to tell the mobile internet connectivity rate in particular countries, and you can just contrast it and just highlight one country and have, if you're talking about maybe South Korea or India or USA, whatever, you have to use this contrast very effectively and emphasize your point by using appropriate contrast. The data slide should not be about humongous data. It should be about the meaning of the data rather than the entire data. So there are various ways to present it. We have to just tell that 72% of the surgeries in India are made, and you can do something like this slide. There can be a pie chart. But if you see now this slide, the same message is more effectively communicated by this picture and the simple line, or else in the other way around as well. Then also start with an action word and avoid complete sentences as if you have copied it completely from the book. There should not be any spelling mistake even in PowerPoint presentation. Use a spell check. Avoid punctuation marks unless it's a quote. Avoid unnecessary animation like slide transition, slide running here, slide coming from top, coming from side. This is all unnecessary distracting and doesn't help much. Most important thing, remember, less is more, less content, more is enough, and keep it simple. Don't make it very complex with animation and transitions. Use contrast wisely. This is the slide when you have to tell without contrast you are dead. But if the same message is more effectively communicated by using appropriate color contrast, use the appropriate colors background slides. If you have a large venue, you can have dark background. If it's a smaller venue, use a lighter background. This combination need to be avoided: red, yellow, and red on blue, and red on white. These are all very not soothing to the eyes. The better color combinations are shown here. Maybe a blue and white, or black and orange, etc. Fonts, avoid uppercase because audience needs longer time to read uppercases. Instead, use uppercase only to emphasize a particular point. Font, ideally around, for heading it should be 36 to 40 point, and for the text it can be 32 or 28. Sans serif fonts are best, mostly Arial or Helvetica, which should be used. They are good for seeing from a distance. And serif fonts like Times New Roman, in which we type, they are better for printing and reading the text. So these are some of the fonts. So use Arial or Helvetica. They are good fonts. The size we already discussed, around 44 to 60 for heading, and 32 and below for the thing. Use bullet points. Bullet points are effective, but don't make it a monotonous bullet, 10 slides of bullet points. Just effectively communicate your point. Alignment is also important. So how you are spacing your thing and aligning is important. So the same message is very effectively communicated by proper spacing. And it's very important to align it in a particular line rather than each line starting with a different start is not very welcome. So have this spacing constant as well. In one upper two lines, the spacing is maybe one line, but the next is after two lines. So avoid that, make it uniform, something like this. And don't put too many text in a slide. This is not a slide, it's like a document, and nobody can read within 30 seconds all these things. So just put relevant things as a bullet point. Pictures, choose a picture wisely, mask identity of the patient and use it effectively. Have in these images or whatever we are using to show the clinical CT and MRI images, use these bullet points or the arrows to show what you want to show rather than the entire CT or the entire MRI. Use before and after to effectively say what you have done and how is the outcome. Don't add too many details in the same slide and then try explaining a complex topic. It's better to make two or more slides and keep it simple and give less time to each slide. Use clear, high quality photograph. Use the screen to maximize so that it can reach the audience even sitting at the back. A small image in a corner may not be legible to people who are sitting in the back. So again, this important slide, whatever is not needed, just cut, delete, throw it. Don't be ruthless here. And for when you're preparing for the big day and the day of presentation, you should be appropriately dressed to the audience, topic, and venue. And obviously, these are some of the things which should be managed. Time is important. Arrive at the venue well in time. Check the preview room. Check your videos are running. Check the facility. Keep to time. Don't don't overshoot the time. Important is voice modulation. A monotonous presentation at times put the audience to sleep. So have voice modulation. Have some unexpected thing that you can ask someone sitting in the audience his experience on this topic, and suddenly everyone then is alive. So use this voice modulation quite effectively. Stage presence, your gesturing, eye contact, everything carries a meaning and make it effective. Posture and stance. So some people and many of these are talking today. They are very effective presenters. So when they own this stage. So you have to own this stage during those 8 or 10 minutes. So to conclude, these are some of the top 10 tips. Connect with the expectation of the audience. Know your audience. What is your target audience and what you want them to learn. Don't read your slides. Effectively present a point and communicate through that. Eliminate unnecessary information. Just keep it whatever is needed as a crisp presentation. Don't go over time. That's very bad. Asking for 1 minute and 2 minutes, and or people cutting you down, cutting your time down and stopping you midway. It's not a very effective way of communicating what you want to. Concentrate on delivery. Face the audience. Avoid monotonous things. Slow down. Pauses. Something like that. Learn your audience. Think again what you wish to do. Again, content is also important. PowerPoint cannot rescue an average or poor content-wise presentation. So you should be talking sense, and PowerPoint is the tool to enhance that content. Content again is the key. Make it a performance, gesture, stage presence, eye contact, well-dressed, effective, and no hassles in between, so that your slides are not moving, your video is not playing. Just avoid all those things. Most important thing, practice, practice, practice. It's an opportunity to make a difference and make full use of that opportunity. Thank you so much for your kind attention.
Thanks, Sachin. I think it was indeed wonderful. Your number 7 point about exceeding time, I think that is our biggest bugbear.
I asked.
It starts right. Yeah, go ahead. It starts right
I
from being a
requested
student.
Apurva. Yeah, okay. I have this problem before presenting, because all these points are so relevant, and such webinars do not happen in which all this thing is discussed. So I requested him for that. You should please do not stop me midway. And
So I think when you are a student, it starts because you think you need to pack in too much information and spend a lot of time in introduction. And when you are trying to say your piece, you are already probably finished your time. But later on also it happens. And I unfortunately think that, I think that unfortunately many of us have got into this habit that going over time is a norm. I think that is something very, very important because remaining crisp is extremely important. I have two technical questions to ask you. One is, do you think AI has helped you to prepare presentations? Because now it is freely available with Microsoft as well as with Google. And many people, I think, are taking help of it. So do you have any comments on that? The second question is that why PowerPoint has remained our mainstay when better things like Prezi are available to people? Go ahead.
Sir, AI will take over lot many things, and there are various good inputs. So recently, I had a conversation with some of the guys from pediatric neurosurgery, and they're saying that there is no need to write books as well, because everything is available on with a click of a button, and even that's not plagiarized. So it's all if you want to write a chapter, it's all there. So this is helping. AI will further, as it is just a starting. and we are also not using it much, but obviously there are things which will with time to come, it will help us a lot to make better presentations. So we are doctors, there are technical guys, their presentations are another level. Maybe those who are in software or things, they are using a lot many stuff than what we are using. So that is definitely the way forward. Again, PowerPoint is persisting because of its simplicity, ease of use, and availability across board. So probably that's the cause we haven't shifted to a better platform, because it's now such a widespread that everybody is using PowerPoint.
Thanks. So, Open, there are some suggestions, questions, etc. Hook is the effect which you were talking earlier. There is a comment on that. And I think second is about proportion of how much your time you spent in introducing and talking about your talk. But Apurva, Dr. Selvan, if you have any comments, questions, please go ahead.
I think it's a very well documented, beautifully presented. Sachin Borkar has stuck to his charisma. Thank you, Sachin.
Thank you, sir.
Sachin, one thing I always seen that you always, have an effective presentation, like you always wear cotton. This apron you always. Today is Sunday, still you have done that. For marking of an effective presentation. Thank you.
So the one point is to be well dressed for presentation. So you should not be. So maybe. So I think small things, and over years, I think I have many times I just watch people not for their content but for their delivery, and we learn so much in conferences. Obviously, I learn less of content and more of all these things, because content is very widespread. So I have listened to Professor Goyal for so many times, but every time he's a different presenter. So his gesture, his everything. So I think that makes us more. It helps to make me better, and I think we should also do. All of you are very good presenters, so that's why I'm there in the hall when you are presenting. And if I feel the presenter is not good, I am outside with 40, something like that.
Thanks, Sachin. We have an outstanding presenter in a better dress than anybody can think of. So we have a person directly from Operation Theatre now. Manjul, start your talk.
Somebody needs to grant me access to present it. Thank you so much, sir. Thank you, sir.
Akshay, please see to it. Welcome, Dr. Manju. Welcome.
Thank you, sir. Thank you.
Thank you, ma'am.
Are you able to see my screen?
No.
No,
Not yet.
your face and PGI behind you.
Yes, we can see, sir.
Can you see it now?
Yeah.
So it's a
Hey, you got this.
Hook. Nice hook.
Nice hook.
So I'm starting it. It's a recorded one because I was not sure whether I would be able to finish the case before or not. So, good morning, everyone, and thank you, NSSA, for giving me this wonderful opportunity. Writing your first article is like having the romance for the first time. It's like coming out of certain age and entering into another age. It has all that awkwardness, confusions, questions, and misleading friends which you must have faced in your first courtship. I'm sincerely thankful to Dr. Onam Verma, who is actually an upcoming neurosurgeon, and Patrick Blomstead for helping me in preparing this talk. And I am ever indebted to these gentlemen who guided me in my life at different stages of time. The first person is Dr. Sanjeev Gupta. He was my rookie faculty in Bhopal, and I wrote my first article under his guidance, which got published in International Journal of Surgery. And my later on articles were written with help of Amay and Dr. Sandeep Mohindra, hugely encouraged by Dr. Sanjay Bihari. Dr. Suri told me how to polish them. And then Dr. S.K. Gupta and Dr. Atul Goyal, they never let me sit in my comfort zone and kept pushing for writing. So what is the prerequisite to write a scientific literature? We all think what we should write. The first and foremost important thing to start your article is to change your attitude. You need to have a burning desire to write something. If you want to write something which people should read, you should notice them. You should see through the things. You shouldn't just see, you should notice them. Don't just notice, question them. If you're not happy with the answers, challenge it. And if you are cornered, then mark your point with your counterpoints. In this way, you can become an iconoclast. Like Professor Goel, with his theory on carry malformation, he keeps publishing over it. He keeps hitting the wall, and one day he will break that wall. You should start writing today. Write anything, write often. And before you write, it is very necessary that you should have a mental preparedness for the research, because this is a dedicated job and this is a part of your curriculum. Build a capacity to read and build an imagination. If you have an idea, you should start scrubbing it, anything on it, but it's better to have a laptop, better than a tablet, and learn typing today. Capture your clinical data, your operative notes in good cameras or camera phones. Make yourself familiar with these softwares, Word, Excel, PowerPoint, Adobe, EndNote, Microsoft Movie Maker, and better to have your familiarity with the statistical front. Sources for the general information, I do not shy away in getting an initial information from the Wikipedia or up to date, but they are not quotable. And many times they are not very trustworthy. So if you need some trustworthy, go through the Google, and Google would take you to some trustworthy resources, and usually that is the PubMed. To find the answers to your questions, you need to go through the scientific literature. Start going through your textbook first, because this is usually an unbiased one and a good distillation of the last work done on that field. Then start looking on the controversial aspects published in the literature on your topic, which is in sync with your patient's question. Once you have found the right question, you need to search the literature. While searching, try to find the relevant articles on different platforms. Usually it takes close to around 15 to 20 articles in journals of good repute. Go through their references, find their cross-references, check them, and this is usually in their reference list. There are various online research databases like PubMed, Scopus. Cochrane is excellent for systematic reviews and meta-analysis. Try to find Sci-Help. The PubMed is actually the main source, and this is the temple where you find practically all the published good literature. Whenever you need to find any article, you should use the keywords, or you should go through the author over there, the year of their publication. Use the keywords. Like if you are doing for a deep brain stimulation, find the electrodes, battery, chargeable, rechargeable, movement disorder. You can find recent published articles, abstract from there, and in the end, you will find the cross references over there. There is an excellent PubMed tutorial which guides you how to go through it. Explore it initially. It's a time well spent, and you would definitely thank me for my recommendation. There are various other resources. If you're not able to find, your institution does not have a subscription to that journal, you should join ResearchGate. Follow those authors on social media platforms. Request them with their personal messages, and most of the times they are happy to share their article with you. I found it repeatedly. One of our earliest articles are the case reports. These are good to increase your number. If you want to know how to publish a case report, you can go through the CARE case report guidelines. And these are excellent resources where you can find how to write an article. Many times people ask me that they do not have anything to write about, but they still want to write. So I say that I encourage them to do the systematic reviews and meta-analysis. There are various crash courses such as the SRMA notes. These are freely available. There is an step-by-step manner systematic review meta-analysis course, how to do it, in the North Carolina Institute website, and you can go through it. It's a very it's just a 2 hours job, and you will find some excellent crash course in doing it. This is a WFNS published article on how to interpret the systematic reviews and meta-analysis by Angelo Scolias, and I recommend all of the people who want to do systematic reviews to go through it. Once you have started writing, manage your library. You should put a manuscript folder, designated folder of the reference article over there, create a definite roadmap, like I put the author's name and then the year and a short title of that particular topic, and maintain this throughout your career. If you're not well organized, this is definitely a waste of time and resources. In the later part, I can tell you how to use the EndNote, Zotero, or these are the citation managers, so you can keep a repository of your articles, reference articles, and go through it. EndNote, you can go through the EndNote tutorial. Limit the number of your library folders in the EndNote. Do not make it a micromanagement basis that becomes confusing. Zotero is free of cost available. You can download it for your various platforms. I personally like EndNote, but this is from a subscription basis, and with its LinkedIn feature with the Microsoft Word, it's a valuable resource. This can manage your library, this can manage your PDF, and this is very good when your one article gets rejected from one journal. It immediately changes the citation styles. So the basic requirements to write an article is, first, you should have a knowledge on the topic, and while you are reading, you become an expert over it. Always use simple language, straightforward language, stick to the text, follow your set pattern, be structured in your writing, avoid using multiple synonyms for the same thing. Maintain a uniformity over there. Do not use the terms which may lead to the misunderstanding. Use commonly used abbreviations. Try to put the things in active tense, not in passive. No long, boring sentences. And as there is a word limitation, try to use tables and figures. Most of them require a Times New Roman font 12 with a single spacing. Pages should be left spaced or equally spaced. Heading should be in the capital bold, subheadings in bolds, and sub-subheadings in italics. You can put references on your own, but it's better to put with the EndNote or Zotero. And tables and figures should be towards the end of the article. The first page file, which includes your authorship, the title, and the keyword, should be written first. Then always write the material method. Reviewers look at this with the skepticism, and this is going to decide your article is going to be published or not. Results should be concise, be true in it. Do not boast your results, but tell your results, followed by the discussion and then the conclusion. Then you should write the introduction, which sets the tone of your article once it's published, and the final, you should publish the abstract over here. So now start writing. Open a Word file, name the file. Of the papers that you have read, find at least 5 articles which match your article, take their printouts, put in front of you, and now start writing over here. Material methods are actually the backbone. In the initial part, you can actually imitate the style of the 5 best articles which have been published over there. Check how they have formatted the sentences, their words, their expression, their sentencing style. If you are finding something which you are writing and they are not writing, ask yourself why. If you are finding that they have written but you are not writing, then ask why. And accordingly, you can modify your article and cover the deficiencies in your article. In the initial part, if you are not able to go through it, first you should find some text from one article, another text from another article, and try to imitate their style. As far as the word count is concerned, never be shorter than the shortest article, shortest written so far, and never be longer than the longest material method written so far. Results is the substance of your article. In the results section, be concise. Just show the results. Do not mix up materials and results. Do not discuss your results in results. For that, there is a separate section of the discussion. Be economic in your words. Use tables and figures. Use the flow charts to show your results and the material methods. And one important part here is maintain a uniformity, like number outside the bracket, inside the bracket percentages, and follow that same rule all the time. If you're not good at the statistics, this is going to kill your prospects of doing the meta-analysis. So learn the basics of statistics. Discussion is the part where you discuss your results. This is the most interesting finding first. Discussion usually has 2 sections. One is a general discussion, which is a distillation of the published literature, and second is related to the findings in your article. Be candid in your accepting the limitations, but do not be discouraged by them. They are going to set the tone for your future articles. For conclusions, highlight your most important findings first. Shorter the better, and do not be pompous over here. Be humble in recommending anything. Then you should start writing the introduction. Introduction is the first thing which any reader first. It sets the tone of your article. Be short here, concise here, but give the problem statement and tell the reader that how are you going to explain it there. This is the deciding factor for the publication of your article. Once everything is done, now put it into the sequence of the key titles, subtitle, keywords, abstract, introduction, material method, results, discussion, conclusion, references, tables, figures. Now read it again and again. Abstract is actually a cut paste from your main text with certain change in the flavor of the text. And then comes the time of the submission. Submit to the journal. If you find that this is an excellent article, try to always aim with a higher impact factor journal. Even if it gets rejected, you can improve on its deficiencies with their comments. Follow the journal's guidelines for instructions for authors. Reformat and resubmit it. Which journal? Go to the PubMed, find which other journals have published a similar sort of articles or on the same topic, and strictly follow their rules for the publication. While publishing, do not corrupt the world literature, because what you push in a publication, by fudging the data, this is going to corrupt the world literature and the future generations. I encourage people to publish negative results, complications, non-explainable things, but do not hide the facts. If something is already published, and if you have a larger number of patients, you can still publish it. You can publish it again and again to say that the facts and the timeline has not changed the results. After a certain age, the main incentive, like after writing close to around 380 articles publishing, the incentive for me in writing is that it gives me an opportunity to learn new things and to be updated with the published literature. This is the incentive for me to write now. Writing is the best meditation, and you should do it. Thank you so much.
Thanks, Manjul. I think you have given good guidelines. I would like Apurva to comment, and there are no questions in the chat box as far as I can see.
Thank you, Dr. Manjul, for the wonderful talk.
Thank you.
There are two questions, sir, which I would like to ask. One is that when we do an extensive literature search on any given topic which we want to publish, there usually be a lot of articles, some of the more recent ones and some of the more earlier ones, usually when the case was first reported or mentioned in literature. Now, when writing an article, usually in the younger generation, there is a tendency to quote the more recent ones and leave behind the earlier ones which were initially reported maybe in the 1980s or 90s. But then we have a letter from the editor that, my article was not referred to, and sometimes the senior authors take an offense. So how to go about that? Which articles should be mentioned even if they have been published earlier, and should not have been, excluded from our review of literature and the list of references? And how to avoid being caught in the letters which we get from the editors? That is the first question. The second question is that when we are publishing, even after multiple checks and repeats, sometimes there's always a gray zone of plagiarism. And many of the people whom I know have been caught in that. So how to be absolutely sure that there is not much repetition and there is no scope of plagiarism, even when we are very sure on our part? Thank you.
Thank you, Apurva. Both the questions are very relevant. The first question related to the comment that they have not been quoted or they missed quoting that important part. So most of the times we need to muscle the ego, and we can do that again for that one. And if there is any really a good article which has been published in the past, though it has been a part of the earlier literature in those times, they have definitely contributed to the recent literature with their publication at that particular time, related to that the technologies and the armamentarium available at that time. So including that into the discussion, I do not discourage it. I always include that part. Supposedly, if you need to write about something on the aneurysm, you will have to always quote the results of the clipping, and then you have to go all about the coiling. So that definitely helps in giving you a certain edge. And there is no harm in writing or including it into your discussion. So whenever there is such a recommendation come, I usually try to honor it. There's no harm in honoring it. It's a published one. The second part related to the plagiarism, there are so many softwares already available, and you can on them. Most of them are actually free, or you can go to some institutional libraries and they can do it for you. They definitely give you a certain percentage of the plagiarism in your article, and accordingly you can work over it. So plagiarism, if you have a routine Microsoft Word also, they also give you a plagiarism check. Hello. So that's not a much difficult problem these days.
Parito sir also has a comment. Are you there, sir?
No, there are some websites where you can send it to them and they will correct your plagiarism. But I don't encourage you to plagiarize. but there are times when even after many times you
Yes,
have plagiarism percentage exceeding a certain level, and you just pay them 5,000 rupees and they will correct it and give a less percentage. So you can use those things.
Right.
Thank you, sir.
May I ask one question, sir? What is your opinion related to use of AI in writing or publishing articles? Because with AI being so easily available, especially like ChatGPT or Jenny or many AIs available, does it help in writing an effective article if you have your ideas very well in your mind, or is the age-old method of going through the literature and writing on your own always helpful?
It would be a slightly longer answer. The human race is going through a difficult time because of the AI, and it is affecting your publication also, because we have artificial intelligence and a lack of a common sense, a congenial stupidity which is there. So far, whatever is the AI is definitely going to come in a big way, and people are using AI in writing, but the AI is actually working on the published literature. There is no new thought over it. And it tries to find out the literature which is commonly accepted. If you have a different viewpoint, but it is not a popular viewpoint, probably it would not consider it into a distilled result which they give as a synopsis to you. So they try to be politically correct in that way. So if you ask somebody something about some particular surgical approach, they will just take the popular surgical approach. If you ask about an acoustic neuroma, they would put everything about the RMSO and they wouldn't talk about the translabyrinthine over there, because that's the most common one. So the problem would start happening when this software would start interpreting the data and they would start making new logarithm out of it and to create a new sort of a logarithm with the existing data. So far, they're just viewing it. In the next stage, the AI is going to interact with that existing data and to create a new logarithm. That would become a trouble. As far as writing is concerned, on a synopsis, writing on a basis of a synopsis is not going to help you. While you write, you are actually starting a philosophy. You are developing a philosophy while writing something, and that philosophy gets sharpened over the course of time. If you read a whole page, you may find some 2 or 3 lines important, but the 2 paragraphs above, 2 paragraphs below, they actually set a tone for those particular lines which you now are able to comprehend, and you could make a synopsis out of that. Just making something from the AI, you are killing that possibility of developing a philosophy over that. You are actually borrowing from something from somewhere and you are just putting it for the next platform, and that's not going to help. So I always ask people to read the printed material in a proper traditional textbook manner rather than doing it on iPads or on just on your phone, because they fail to make you develop a picture memory of the things. While reading a book, you know that your figure was on the left upper corner, तुमने वो पन्ना मोड़ा हुआ था. Those all things actually help you in remembering the things and developing your philosophy in the long term.
I'm sure people would have that for digital media as well very soon. But the point is taken. I think it depends a lot on how you have probably grown up. That's what my youngsters tell me. So I think, yes, Rishabh, you have a question?
No, sir. That was the only point I was trying to make. We emphasize a lot on not corrupting the literature, but with the recent advances of AI and being so freely available, I don't see a future where the literature will not be corrupted. It is only few ideas which will help to collaborate the literature, but there will be chances of having corruption of the literature.
Whatever little help I have taken for either writing or for making PPTs, I think one thing definitely the ChatGPT or Gemini definitely helps is to give you a little bit of perspective as to how you should start and how you should end, and probably gives you some sentences which might make it more palatable. But data wise, I don't think unless you have something to say, you cannot make a good presentation. I mean that, or can write a paper. So I think that is your contribution, and there you have to be very careful that you don't corrupt it any further.
Yes.
But who comes next now? Apurva? Is it
Apurva.
Paritosh or?
Sir, this is now Dr. Jayesh. Dr.
Jayesh is
Paritosh,
coming
what-
next. Ah,
Uh,
Jayesh has a very important topic for the day, and I think you have to learn it from the people who are ruling us today. Come on. Sorry, without any aspersions on the community, I think there is a definite advantage in learning from you.
Thank you, sir. So really, it is very important, patent. So we'll make it brief. This two person, I think it's very important, who said that Dr. Warren Buffett said the best investment you can make is an investment in yourself. The more you learn, the more you will earn. And our great Ambani sir said that convert your skill and knowledge. There is only one way, when you can convert into health. And this is the only idea, that you can convert your skill and knowledge into wealth. The wealth and richness are different. That wealth is having rich plus famous plus success and happiness. So that is the one way you convert your skill and knowledge, and the patenting is one of the way that will help in our field. So why patent? By patenting, you can own the invention for 20 years. You can use to build a business, you can rent it, you can completely sell the patent to other companies. So one of the way to make the money, of course. Who can apply? Any business owner, any research scientist, professionals, master degrees, PhD holders, and all students who intend to learn more about patent can apply for patent. What is patent? Patent is basically the grant of exclusive right to the owner to exclude other from making, using, offering for a sale, or selling or importing the patented invention. So this is basically patent. So before you start, if you desire to having a patent application, there are three basic criteria which any invention must meet in order to deserve a patent. Novelty, most important, novelty. You see, every surgeon or a physician or the researchers always thought that my idea is original, but 90% of the time, somewhere in the world, somebody has already published it or patented it or are in working progress. So definitely, legally, we should find out that is it the novel idea, and I will tell you how to find out that. Second, obviousness. And third, it has to have an industrial application. These are the rules for patenting. Now, this is the general procedure. These are the 9 steps. I will speak one by one, but first steps, once you feel that, okay, this idea is good. Suppose I want to patent one screw or design a screw first, and you feel that you are conceptualize this invention, and first you make a paper draft. This is called invention disclosure. You write everything, you draw everything, and you have a one invention disclosure. This is not legal. Then you make a team. It is absolutely important. You find the partners, you find your mentors to discuss it, and you also have to discuss with the patenting attorney if you require. For that, on the first day, there should be a non-disclosure agreement which make medico-legally that property safe, not only for your aspect, for your partners also. Third, how to find that this is the original idea and there is no such a thing has been happened in our country. So that's called patent search report. Either yourself you go for it, or your agent will go for it, and that is basically not only the googling, but you also go through all the medical legal sites also where you can find out that. Then it takes 7 days. Then you apply for the provisional patent application. So provisional patent application, the day of your provisional patent application is your day. That will count for all the medical, legal, and administration aspect. So that day is important. Why provisional? Because it will give you a 12-month time to complete your project by every means. In that, after 12 months time, you apply for the final patent application. Once you apply the final patent application, within 6 to 8 months, means The day you started the provisional patent application, after 18 months, it will going to published. If it is, of course, novel and all those things. It will be published in Indian Patent Journal. Once it published, you have to apply for request for examination for patent examiner, so that he can give a viva or your physical interview. He will check your things and then they raise the queries and all the things, and then after step 8 is either they grant or refuse the patent. And last step 9 is the publication of grant or patent. You will get a certificate. This whole process takes 4 to 5 years. So as I said, if you desire to having a patent or one original idea, let's start with it. You first step, you have invention disclosure. So whatever you think, just write it down on the page. Describe the invention, how does it works, and most important is you find out what are the similar solution or the product is available, and how your product is or idea have an advantage over that, which is very very important because you have to submit that things, or he will file raise the query about your product. So you should be ready for that. It includes diagram, it includes sketches that explain your working of invention. That is step 1. Now, as I said, you make a team. You need to protect the confidentiality by way of signing a non-disclosure agreement, and this is illegal. And this is by both or 3 parties to whom you are discussing the invention, and even before a patent attorney, you should have this non-disclosure agreement. Step 3, is it a novelty? To confirm that, I would suggest you hire one patent attorney or the agent, which are easily available anyone on Google, and you ask them that I'm thinking on that, let's sign the NDA, this non-disclosure agreement, and he will take a professional charges of 12,000 to 20,000, but in the 7 days period, it will tell you that is it novel. How? This is Indian IP site. It's called Indian Patent Government site is there, in which there is a search system. So there is one way you can put this your whatever the idea or title here, and it will show you all the published and till date granted articles and things in this site, so you can check it out. Apart from that, your agent have to go through all the medical legal sites and data, that is there something phishing medical legal thing is going on about that subject. He will find it out, because it has not to be a such a things. And third thing, of course, he will go through the Indian Patent Advanced Search System. Now you know that okay, this is novel and non-obvious. Then you file the patent application, provisional and complete. There are 2 types. How to file the patent application? This is the website, IP website, the Department of Promotion of Industry and Internal Trade in Government of India. And either you go through the online article or online e-filing, either this website through post or can be submitted by hand. You can go in the Mumbai, Delhi, Kolkata or Chennai. There are 4 offices. Definitely, I suggest you should have a patent hire or patent attorney for file the application. You can do yourself. You can go through this site. Why provisional? Because you get you have to secure the date. Because suppose somebody other person is working in the same idea or the product somewhere else in the country, this date, provisional patent application, is important, because at the end in the medical legally this date will consider. So be early, because you will get a 12 months time to develop this product. It is very economical, takes just 15,000 to 25,000 by your patent attorney, and by government fees is only 1,600. After 12 months, you are ready with this invention, diagram, embodiments, claims. Then you have to apply the complete patent application. Then this is the journal. This is the journal. It's called Patented Design Journal. After 18 months, it will appear in this as a complete product. And there is also option of early public publication if you want it. If you want to go too fast, there is some cost of 4,000, but you can do it. Now, after publication, you have to apply for ROE, called Request of Examination. Fees is 4,000. This RFE is ideally should be done along with the application once you apply on the day 1. So basically, you are asking the patent controller, okay, I am submitting this patent. Now you have to check and access. That controller give all the information to the patent examiner, and they will mail you the objection raised to the patent application. That can be by examiner, that can be by your opposite party also, because it will now it is in online, so everybody can ask, and they will also inform the queries, the opposite party. Okay, this come to us. Do you feel so? This is a different from your product. Then you have to prove that your idea is really patentable, novel, and without dispute compared to others, one by a scientific argument. You have to write proper documents for that. And once they feel that, okay, this is a novel, this is an industry application, then that will be published in the Indian Patent Journal as a granted patent, and this kind of patent certificate released. Now, this whole process got 4 to 5 years. Now, this is very important, the royalty. So let me tell you, if you are working in the government institute, this is not your property, this is the government property, their institute properties, their medical college property. So you won't have any financial benefit out of that. You can have only your name. If you are in a private practice, it will be yours property, provided that at the time of joining the private institute, they will always give you an agreement or clause. I suggest you remove that clause, that any kind of patent or new invention which can have a financial benefit, I will not going to share with that institute. You should remove that clause, because that doesn't matter and they will don't care. So if you are planning to do that, that is absolutely negotiable. You should remove that clause from your agreement. Then it can be yours. Once you do that, the next step, you should find the companies which you feel that your product can be sold and marketing. So that commercial bargaining with the industry should start with the 5%, and it is ranging from 5 to 30%. So that financial leader said you should start with the 5 to 10%, and in initial agreement you should say that in 5 year or 10 years time it will raise 5%. You should reach at 30%. Otherwise, it will remain same till your 20 years. This is 8 to 9 steps would already I summarize. These are the list of document for patent application. You should go through it. Now, overall cost, if you go to the government side, it is 8,100 rupees if you apply it for in yourself. Not it's a hard task. It's not like a complex matters. But if you go with the patent agent or attorney and you ask to take help, then they will take 1.5 to 2 lakh charge, and you will be comfortable, of course. And total process gets 3 to 4 to 5 years. Now, let me give you this example. So this is our patent, which when I was in ACPG, we have applied at 2017 with IIT Kanpur. So these are the two institutes. As I told you, the applicant is always the institute, not you. You are just one of the inventor. And this is the title. We have invent the C1 C2 destructive reducer. So you see this, we have applied at 2017. They have asked for request for examination in 2018, published in 2019, and this is granted in 2023. So overall, it takes six years. This how we should make a graph and design and then model and the publication. So thank you very much for your attention.
Thank you, Jayesh. I think a very important part today, because there are a lot of innovations happening. Many of our colleagues are doing it, and what is the correct way to not only use it properly, but how it can be help you to develop your own self, as well as make it available to people. These things are very, very important today. Any specific questions, Apurva, Dr. Selvam?
Yeah, Dr. Jayesh, thank you so much for the talk, because I think many people now would be quite inspired and do it. I have two questions. One is, once we get the patent, as I said, for 20 years, we can hold on to it. Is there an annual maintenance fee also which has to be paid to the government?
No.
It's so one time. It's a one-time fee. Yeah.
Yes.
The second thing is, can we apply for a US patent also? And if we have a US
I
patent,
mean, Indian patent versus international patent. Do you?
yeah, so if you like the patent which Dr. Jayesh and the institute have got is an Indian patent, what if we want to get the US patent as well? Can an implant or an innovation hold both the patents simultaneously, or is there any rule, or is there any charges which have to be made? How do we go about that? Or can we directly apply for a US patent and get it approved in India?
Apurva, I'm sorry, I have no idea on that. I will work on that because
No, I think it is possible to apply for an international patent from India itself. You can apply for this. I don't think it is specific to US, but you can apply for a national as well as international patent.
Okay. And unfortunately, I think Dr. Goel is not here in the panel because most of the patents which he have, which I have seen, are patented in the US, and he also has now got the approval for India. So he's not here to comment on it. But I also think that it is possible. And the merit of a national versus an international patent is something which I think we have to decide.
There are rules which is given in this IP website. It is just 1 or 2 page. Everything is very, very, uniformly written that, and everybody has to just follow it. Because I tried it, so I know, but I have no idea about a US patent. We have to check for that.
No, here the national patenting is different for Indian users, and international patenting is different. We have to apply for both. You have to apply for both and get the permission from both, because see, the products or whatever you have done in India is different, and what you have done in UK or Germany are different. And if you have to go globally, you need to show your work in the global platform. They have to accept that this thing has not been done in Germany or Italy or France. Then they give the things. It takes more than 10 years, 8 to 10 years. What I have for the microscope enhancements I have done with the G's, it took almost 8 years.
Nice information.
Especially for exoscopic utilization. It took, and again, let me be, it's a closed group of our own people. There's a lot of discriminations.
Yeah.
Lot of discriminations. They, if it comes from Michael Lawton, within 15 days it is sanctioned.
Oh.
If it comes from somebody else, a lot of questions, a lot of scrutinies, a lot of things, it happens. But for global acceptance, you need to take both Indian as well as the Western, whole global trial. Not only American market, whole global, you need to take that.
Exactly my point, sir, because when we go for some live operative workshop outside the country, if we are using for implants, as far as we are concerned, if we use a Medtronic or some implant by a Stryker or the Depusynthesis, we are very comfortable in the use of the implants. But if we want to use implants of Indian name, which are not available in the sister companies, then many a times we have had to take special permissions from the hospital or from their government to allow the use of Indian implants because they are not mentioned in their list of approved implants.
That's right.
So we have faced many problems in Brazil, in Nigeria, many of the places where we went to operate because our implants are not approved for use.
Exactly.
So it's always better to have both the implants so that this distribution of the Indian versus Western can be there can be a sort of a bridge. Otherwise, we will not be allowed to use the implant.
That's right.
Because they don't have the patient safety parameters and long-term efficacy use as far as their patients are concerned.
Very true.
Yeah, Purva, we can go ahead.
Jayesh, may I just ask a question? Is there any expiry period for these patents? Do we need to renew it again and again once you have obtained
20 years, Manjul.
Okay.
20 years. The first application, then you have to do.
Okay.
Dev Pujari sir, can we move?
Can we go to the next thing?
I think we can go on to the next talk. You can invite Purva.
Yeah, so I request Dr. Sunil Furtado to give his talk on finances and neurosurgery, how to nail it. Thank you, sir, for accepting my invitation. Eagerly waiting for your talk.
Dr. Sunil, we are not able to hear you. Hello, Dr. Sunil.
Can you hear me now?
Yes, sir.
Yes.
Yeah. So yeah, thanks again for having me on this program. Thanks the NSSA and Jayesh for having me here. So this is a different talk from what we've heard till now. This is to do with finance and neurosurgery and how we should nail it. The disclosure, I may be holding some specific investments, but then they are not recommendations for any future investments or anything that I would recommend here. So this is a picture of guys who work in a software company in Bangalore. And this was when this is a representative picture, but when I was in college, I saw this picture of guys in Infosys who wanted to kind of retire at a very young age. They had probably earned in 1990 or 92, they had earned about 45 lakhs of rupees and they wanted to retire. But let's see what had happened over the period from 1990 to 2016. If that person had 56 lakhs, it would be worth around 7 lakhs in real buying value in the year 2016. And then that would be because of inflation. As you know, inflation, we all hear about the numbers. We all hear about the inflation numbers which come out every 3 months or quarterly or on an annualized basis. So basically, it tells about the increase in the prices of goods and services, which can occur over a period of a year. And also we have another index called the Consumer Price Index, which takes into consideration all the consumeristic attitudes and purchases which an individual or a family makes. It could be to take care of someone, for medical uses, for luxury items, clothes, transportation, and everything. So if a person invests a lakh of rupees in an FD at 7% interest, he gets around 2.16 lakhs in 10 years. But considering an average annual inflation rate of 7%, the buying power of that 2.16 lakhs would be about the same as 1 lakh of rupees, which he had in hand 10 years ago. So if that person, these persons here who were happily enjoying in 1990, hadn't done any prudent investment, they would have been drowning by now. So why do we need to invest? We need to invest because of the cost of living. We have unknown expenses, both direct and indirect. We must all be aware that about 60% of our earnings go as taxes, which may be again direct or indirect taxes. And what we've seen in the last decade or so is that the shelf life of a doctor, be it a regular specialist or a super specialist, is shrinking. There's more competition. There are more doctors coming out with the same degrees or the same specialties. There are advances in procedures and technology. And a person who's learned a skill today, his skill may be redundant, both by technology or by a nucleate on the block who has just come and has an innovation to the same procedure which can be done much better. So as doctors, we have higher disposable income, but we don't spend that much time with prudent cash flow and debt management. As doctors, we don't have a good social security. Our industry is ourselves. We are the brand ambassadors, and we must plan for our own retirement and contingencies and unforeseen events. So when we stop working, our industry stops working with us, our individual industry. And our professional earnings peak in the 4th to the 5th decade. And we have different priorities. Maybe from another person, we have priorities for pre-med education for our children, housing, travel, or probably luxury, spend more on luxury purchases. But the common mistakes which doctors make are we devote a lot of time to our profession and less time to manage our finances. We leave it to others who may be competent or incompetent. Doctors may over-concentrate on real estate and gold and metals, precious metals, and old-timers can invest in fixed deposits, which may not, as I showed you, give you that much of returns. And we tend to get a lot of advice from our friends, chartered accountants, or even patients, and they are probably some of the advisors to many doctors who are planning to invest. So just look at about 2 crores that you need today. If you need to, for example, spend 2 crores, that works out to spending of nearly 10 crores per year in 20 years. For this amount, you need to save about 1.3 lakhs per month at not just 1.3 lakhs, but at a return of 10% to get to that amount in 20 years. So what are the three parameters to assess the suitability of any investment? One is return potential, the safety of your investment, and liquidity. All these can be grouped together into a class known as an asset class. So let's see what asset classes we have. Most of us have seen real estate. Ideally, 25% of our investment should be in real estate, excluding our own home where we stay. And people assume, including doctors, that real estate is a safe investment because it is not subject to daily rates and trading. However, getting premium real estate with clear titles is a problem. Liquidity is slow. You need to raise that capital for some reason, education, health. Otherwise, selling it becomes a problem. And once a person knows that you want to sell, it becomes a distress sale, and then you don't get the right price that you want. And again, doctors are the highest investors in real estate among many professionals. That is, they invest a lot in secondary real estate outside their residence of stay and hospital. The other avenue of investment is precious metals. About 5% of our investment should be in tradable gold. Earlier, gold was bought as either coins or biscuits, and then you had to go to your neighborhood jewelry shop to sell it. But now you have exchange traded funds, which can offer a real-time value, a good price, and fast liquidity and transparency. Everyone should have an emergency fund. It's recommended that you should put around 4 to 6 months of your earnings into an emergency fund. Emergency could come anyway. It could be as a health emergency. It could be a financial distress for someone in need, your relative. So always have 4 to 6 months of your earnings in emergency funds, either as fixed deposits, mutual funds, which can be redeemed early, which are safe. Company deposits, again, which are highly recommended or highly rated. And as I told you, exchange traded funds, which could be either local or international. Coming to the other avenue of investment, we've all heard of mutual funds. The first mutual fund was set up by the government of India as the UTI. The first SIP was started by the Franklin Templeton Group. And the most popular group of fund schemes which invested directly in equities was the UTI Master Share. But one should have an investment horizon of about 3 to 4 years. Investments in mutual funds are not for short-term gains, either medium or long-term gains. It's a little busy slide, and we've all heard of SIPs and how SIPs are shoring up investments in India. A lot of the public is investing in SIPs. So if you look at the power of compounding, what happens is if you don't take the dividend out of the money that you invest in the mutual funds, it gets reinvested in the mutual fund scheme, and then the power of compounding acts on that, and over a period of time, you get a compounded return on the investment that you make. Just an example here, you have a Sundaram Focus Fund, which had an SIP of around 10,000 per month. That if you had diligently invested the same amount over the last 20 years, you would have got about 1.12 crores. But just to understand that, for someone like me, if you had invested 10,000 rupees 20 years ago, that would be on a stipend of around 15,000. So one should be a little careful with these oversounding numbers because it depends on individual's capacity. I would probably invest around 3 to 4,000 and you would not get 1.12 crores with that amount. But again, it just highlights the amount of compounding that you can do by investing in mutual funds. And again, you need to know that the mutual fund is also given a good rate of return because you also have to take into consideration the inflation over the period of time, because the same 1.12 crores, which was there about 20 years ago, doesn't have the same value today. This is what I initially told you about, the power of the investments in SIPs. I won't really go into this. These are the various schemes that are there in mutual funds. Most of you are aware of it. But what I'd like to share is if you start early investing in mutual funds, especially in equity mutual funds, there may be periods of ups and downs. But over a period of time, once you have more responsibilities as a family person, you could systematically transfer every month a portion of that amount which has accrued over the period of 20-25 years into other schemes like your monthly income fund scheme, a long-term duration fund, or a hybrid fund, because that would safeguard your money, which you would probably need for responsibilities, family responsibilities, education. Just imagine, like, if during the COVID, no one knew that the COVID would have occurred in 2019 and 20. But then if you had everything in equity and you're planning for your son's or your daughter's education, and you had all of it in equities, that would have crashed. But if you had a plan of having a systematic transfer wherein you transferred money from an equity to a hybrid or a corporate bond or a long-term duration fund, that money would have been safe. And also you would have had a fixed return, which you could have also used, and also use that capital which has been transferred for your responsibilities. Coming to equity investments, all of us would like to know more about it. As in the case of AVMs, there's a rule that you can apply. 100 minus the age is the percentage of funds that you could invest in equities. And equity market is booming. As you know, that only around 3% of the Indians are invested in equities. We have about 3.5 crore mutual fund investors with 10 crore mutual fund accounts. And what is also interesting to note is that there are about 65 crore smartphone users in India. So this is basic. I think all of you are aware of it. Share is when a company wants capital to grow, or when they have invested and grown a company, they would like to earn profits from what they have spent in growing the company, the fruits of their labor. So they give it at a premium to the public, and that money can be used by them or for growing the company in the future. So this is just a journey of the Sensex, which was given a base in 1980. Now, of course, you have the NSE Nifty, which is comparable in many ways to the Sensex, but probably more representative of the index than the Sensex by itself. So every there's a business cycle. Right now, we are probably in the early, the top of the boom or the slowdown phase. In the early part of the cycle, the interest rates are low. Small companies tend to take advantage of that, and they invest a lot in producing stuff which would probably stimulate the growth. There are two methods. There's a Milton and the Keynesian method on which the government helps in stimulating the economy. One feels that the government should spend a lot on infrastructure. That's the Keynesian method. And the Milton says that once it's reached a peak, then they should do fiscal control to reduce the amount of money which is floating so that there's no high inflation. So it's a balance between the two. The economy picks up, the interest rates are low, then people identify value stocks, and then over a period of time, there's more interest in commodities, there's more interest in construction, there's more interest in stocks which are supposedly undervalued, and a rising tide lifts all boats, and good and bad stocks keep rising. And then when reality checks comes in, when the inflation is high, the government steps in, increases the rates, and then it's a cycle which keeps on happening again and again. And as a corollary to that, the stocks prices go up and down, and there you have recessions and booms. So there are two ways of analyzing stocks. You have fundamental analysis and technical analysis. I do more of fundamental. I don't do any technicals. Just look at these companies. We have hospitals. I think we are all aware of hospitals, so it was easy to talk about them. We are all into healthcare. So just look at these major hospitals that I've listed. I think you are all aware of them. NH stands for Narayana Health Group. These are the sales on the annual basis for March 2024. This is the profit after tax. These are all in crores. And you can see the profit generated over a period of 1 year ending March 2024, the highest being Apollo. And then you have the equity. Equity is the money that has been spent in setting up or building this kind of companies. So you have an equity of 71 crores for Apollo. Medanta has around 53 crores, and Narayana has 204 crores spent on them. And of course, every share has a face value. The face value is the value at which it has been given initially to the public or at a premium to the public. Here you see Apollo has a face value of 5, Medanta has a face value of 2, and the rest have a face value of 10. So to get a balance, you need to multiply them to find the actual value of these shares. So Apollo with a face value of 5, we need to multiply it by 2 to get a real-time price of 14,000, and Medanta has to be multiplied by 5. So this gives you a value indication of most of the face values are at 10. So you get an idea of how to compare the prices between companies. Another way of analyzing them is the earnings per share, which is the total earning paid by the number of shares which are in float. Again, you need to multiply them so that you get a value which is comparable. As you see, the face value changes, the earnings per share as you see, it also changes because it depends on the number of shares which are floating. Another way of identifying them is to see how the cash flows in and out of the company. These are three different companies. One is doing very well. Trent, of course, stands for the West Side Group from the Tatas. They have very good cash inflows. They invest a lot in developing their stores and their business. And there's a lot of outgo to finance their debt too, but overall they have a positive cash flow. If you look at Zomato, it didn't do too well in the last financial year. The stock had bottomed out around 70, but then this year they've really changed a lot. They've had positive cash flows. There are a lot of investments in their probably dark stores or in their logistics, and they've also spent a little bit of debt financing, which is not much compared to how much they've invested in the growth. And they have a relatively positive cash flow. Kaya, of course, is a beauty clinic. It's also listed. They're not doing too well. But anyway, there is a lot of interest in the stock. But if you look at these numbers are not too great. The other way of identifying them is to look at the price to earnings ratio, which is the stock price divided by the earnings per share. This kind of balances everything out. So if you see, it divides the profit with the equity which is there. So you get a price earnings ratio. If you see here, Apollo Hospitals has a price earning of 72, whereas KMC stands for Kaveri Group has a price earning of 48. So it tells you how valued or not a stock is. Apollo probably has a high premium of the stock on the stock markets. People tend to value it more, and that's why it's quoting at a premium with respect to the other groups. Probably Narayana has a lower premium and compared to the other group. Maybe that's market perception. So these stocks have a higher P ratio, as you can see, and that is because there's higher demand for these stocks because there's an investor fancy. They have people or individuals or investors consider future sales and growth, or they are into new sunrise industries, as I've listed before below. Whereas the other stocks which have a low PE value, these are like institutions by themselves. They've grown over years. They probably are too difficult or too large to fail. They have more social obligations and responsibilities. They throw in some profits. And why are they listed low? Why are they quoted at a low price? Because many of them are government stocks. They have obligations to the government. They have to pay the dividend to the government so that the annual finance bill is balanced. They also have to invest in a lot of social security schemes. Some companies, as you know, like Yes Bank and RBL, have very good low perception in the market because of the financial impropriety that they had, and probably loss of trust. Like Wellspun, they claim that they had Egyptian cotton, when actually they were using only Indian cotton to produce and export to the US. So price to book value, again, averages out everything. It is the market price divided by the book value. These are companies which have price to book value are very low. That means these are probably stable companies that one can invest in. Again, going through all this, we have a list of companies which are hospitals. You can see the price rise over the past 1 year. HCG Group has given 90%, and Aster 32%. Apollo has given you 32%, and so on and so forth. But if you see that the real companies which have given a very good rate of return over the past 1 year are mid-cap and small-cap companies in the healthcare sector, because these are small companies. They have very little overheads. They don't have legacy business to handle like big groups like the Apollos or the Fortis. It's very easy to control a small company, and that's what I mean to say that the rate of returns in a small or a mid-cap company is much higher and much exponential than in a large-cap company. These are the various definitions, as I just told you, that we use for large, mid, and small-cap companies. Large-cap companies are always dependable. They may fluctuate less, but over a period of time, the returns may not be as spectacular, as brilliant as small-cap companies. I'm not going to too much into technicals, but always keep a watch out on your 54-week high and low when you purchase. If a stock is moving below this average line and going up over a 50-day period, it means that there's a strong interest to buy the stock. But again, said and done, doctors are always busy. Unless you are a physician, you don't get so much time to do technical analysis and day trade or do FNO. So I would request you to avoid it as much as possible. I don't understand these graphs many of the times, but if it's not very easy, because if it was very easy to do all this, then all of us would be sitting at home and growing money with these graphs, and most graphs do not follow the mode of the market. So this is a video which I'd like to show. This is one person just dancing on his own, and then he does something and attracts another person, all sorts of gimmicks, and then that attracts more and more people to see what he's doing. And then the entire village turns up to whatever he was up to. And that's when the market has reached its exuberance. That's when the market has reached its top. When your neighborhood milkman, postman gives you recommendations for a stock, that's when you have to stop buying and probably think whether the market is overheated. So the best time to enter a stock is when everyone has written down the stock or sector, and when there's irrational panic on the market. Example like the dot-com crash of IT stocks, the COVID pandemic, or the real estate or subprime crisis, especially with financials in India with the PMD scam in 2016. Currently, if you see, you find that cement stocks, financial and banking, and commodity stocks are very low in India. So always look at companies which have a moat, in the sense they are monopolistic companies. Even if a new entrant wants to enter these companies, like your energy exchange, your IRCTC, even if you don't get a ticket, it still has a monopoly on tickets and food, which is getting served on trains. So these are monopolistic industries. Even if a new company would like to join or come into this in the sector, it would require a lot of investment and a lot of push to attain what these companies are. So these are more to monopoly companies. So these are the investment cycles that we've seen over the last 60, 70 years. Initially, it was the boom from Ferra companies, and then you had IT, you had infrastructure, you have specialty chemicals, and now it's new age companies which are dominating the stock markets. And these are the same investment triggers that we've seen, and the downfalls which have followed after the various scams that we've seen. So I would always recommend to have a coffee can portfolio. These are high growth, high potential stocks. Coffee can investment was usually seen in the United States, wherein individuals used to buy bonds or stocks and keep them in huge coffee cans and remove or see those stocks. These were physical papers that they had, and see how they have developed or helped them over a period of 15, 20 years. And these are businesses which are strong. They may outlive us, and they may help our families. They may survive many generations. And if you see companies like HUL, SBI, HDFC Bank, these are all coffee can portfolios if you invested in the 80s, and they would probably help set up your home, your children's education, or whatever. So if you look at the future, you have companies which are into e-governance, into insurance, which is still nascent in India, and online platforms which could help you build a coffee can portfolio. Those doctors who are not too keen on managing their investments on their own, they have personalized services which will help you with your investments. These are portfolio managers. It's like watching a movie in a premium lounge. You have persons who would serve you your needs. They'll ask you what kind of investment you want and tailor it based on your requirement. Of course, they charge more premium management fees than mutual funds, but it may work out for you. You can also invest in startups. This is a company, when I was doing my fellowship, a lot of doctors were taken as advisors for this endovascular company. And when it was listed on the stock market, many of them became millionaires. This is, again, one of my co-fellow during my fellowship. He went into AI in medicine, and he's got his company now listed on the stock market in the US. So you can also invest in the US using all these broking apps, but there's a higher rate of taxation for them, and a lot of forex charges which come into play when you invest in these. what was my strategy? When I started at the age of 16. I was single and living with my parents. I had no encumbrances, so I invested whatever money I got as a stipend, assistant fees, or gifts in stocks, and went through 2 bull runs. And I learned a lot from the crashes. There was a lot of exuberance. I invested blindly, and I learned when to and when not to invest at that point in time. The second growth was between 24 to 30 years. I invested 80% in stocks. Most of it was coffee can because I didn't have much time to devote to them. So at that time, there were no SIP schemes, and the opportunity at that time was the tech boom. 31 to 40, as my family grew and as I took up more responsibilities as a neurosurgeon, I invested more in stocks, 80%, 20% in mutual funds, and the remaining in SIPs, which were in mid caps and mostly in mid caps and small caps. And I waited for a return at 20-25% to kind of encash on the investment return that I had got. Right now, I have about 70% in stocks, 20% in mutual funds, 5% in long-term debt, and about 5% in recurrent deposits. Again, a lot of it is in long-term companies, which are coffee can. 30% is medium term. Medium term, you think of about 2 to 5 years, and medium term, you think of 2 to 5 years, and less than 2 years is short term, and some investment in overseas stocks. And also, for my children, I've put schemes in their name. You can invest in minors. So I put SIP schemes in my children's name, which would probably help them with their education later. And most of my emergency fund is kept in long-term debt. So in type of market crisis, as I told you, move to FDs, have ETFs, go to defensive stocks like in pharma, in healthcare, because whatever happens, you'll end up brushing your teeth in the morning, you'll have having a bath in the evening, you need medicines for your healthcare. So these will outlive us. So these are kind of defensive stocks, and SIPs will also help you average your thing. Always look at what happens around you. There's always a lot of information online.
Sunil, can we conclude?
Yeah, I'm just about done. Yeah. So always see what's happening, talk to people, and see if you can get any information. So to conclude, you should have a patience when it comes to your investments. Avoid the FOMO just because someone's going to buy those stocks. Avoid day trading. Be cognizant from your mistakes. If you make a mistake, don't hold on to them. Always learn from them and cut your losses. And if you have a strong conviction on the stock that you have, go all out for it. And think about your individual investment rather than what other people are telling you. Again, these are some quotes. Be fearful when others are greedy. The individual investor should act consistently as an investor, not as a business. This is one of my mentors.
Don't forget this. I used to have a drink in Jeffries. Some pretty girl will come and ask me that what do you buy? I tell her buy XYZ. You tell her, she'll ask me what return I get. I'll say it will double in 3 to 4 years. Only I give her the address of the Mahalakshmi race course. So the first thing is everything in life is about maturity. And don't go on scaling your bets. And invest your own money, not your father-in-law or father's money.
Thank you.
Thanks, Sunil. I think it was good from a surgeon to hear so much perspective. I think was very, very, it's been a learning experience, I must say. We actually started or we were young when there was hardly any opportunity to invest. And as you have seen in the last slide from what Junjanwala said, that today I think the Indians are making most of the market investments in India. So it's a big change, and I'm sure there were a lot of things to learn. But we have not taken Sachin Borkar's advice, and I think we have finished our time and 3 speakers are still waiting. So do you want to discuss this, or should we just move on to the next one?
So we'll just have one comment.
Bugani has something to say.
Yeah, one question.
Just comment and then we'll go to Dr. Subesana.
Yes. So one question just want to ask Sunil. Excellent. It was like, an economic, financial, international expert speaking. It was really good. I mean, I really appreciate your knowledge. And you said you started since you were 16 years old. You're equally, it's really nice. But so just wanted to, apart from this, the investments in gold, and land as compared to the shares, what would you, because my take is different. Last 25 years, what we have invested in the gold and land, they have given us 100% returns, 200% returns. Some of them have given 300% returns, which we purchased gold in 2005. What we have today is uncomparable.
Yeah.
So, and safe. And anytime you can dispose it off and get whatever you want. And lands.
You can...
real estate.
Absolutely. I mean, investing in gold earlier was difficult, and it was usually done with the ready cash, which was there in your pocket or otherwise, which was earned. But now with the ETFs that you have gold bonds which are given by the government, and the growth has been rather very well in the last 15 years, as you said.
Exactly.
Again, for real estate, I'm not a direct investor in real estate, but then you have REITs which are listed on the stock market, which are invest in real estate infrastructure and in tech parks or in such other zones which pool money and invest, like you have the Embassy Group and so forth, so on and so forth. So I would rather invest directly to REIT and ETFs rather than to real estate, because with direct investment in real estate you tend to have a lot of heartbreak.
I don't claim to understand very much, but as Suresh was saying, real estate, I think that is converting into REIT. Gold is converting into gold ETFs, as you said.
Yes,
and I think it is partly also dependent on age. I have come to know this very, very late in life. Not been able to take much advantage, but I can understand now after taking some advice from people that it is age dependent, how much you actually keep in equity, how much you keep in mutual funds, and how much you keep in debt. Absolutely. I think as age advances, you have more probably things in bonds, FDs, and debt rather than at the younger age when you have more in stocks and other options.
Yes.
So shall we proceed to the next one? Or you have any other piece of advice?
No, sir. Let's go to Professor Sumit Sinha, who is waiting to give us talk. Thank you, Dr. Sumit, for accepting our invitation. And please start, sir.
Well, can you see my screen?
Yeah, yes, sir.
Can you hear me?
Yeah.
Yes.
Okay. So wonderful, Sunil. I should congratulate you. I mean, I don't know whether he is left already or not, but I mean, really, really commendable, because we as neurosurgeons and as doctors do not know one thing, and that one thing is how to invest your hard-earned money. And many times, I'm talking about 99.9% of the times, we all neurosurgeons especially, we are so busy, we don't look as to where to preserve and invest our hard-earned money, and ultimately it ends up giving this money to a illiterate financial advisor who puts money at all stake, and then at the end of the road you are left bankrupt and crying helplessly. So my piece of advice is this is just to follow Sunil Furtado and make him your financial coach.
My advice is to spend your Saturday evenings on Sundays on a light with a beer or something. Just eat a little every day, every week, and then you can teach yourself.
Absolutely. So anyway, thank you so much for that enlightening lecture by you, and that's wonderful. Let's come back to out of the fantasy world. Thank you, NSSA, for this wonderful opportunity to me to present myself. And the task which has been given by dear Jayesh is a wonderful task, I would say that, because thank you so much, Jayesh, for giving me this topic, because initially I was hesitant, because I mean, you have to prepare a talk, and I mean, you have to spend time to read the books and search the literature, and ultimately I feel like I have learned something at the end of the day. So from this vast literature, I have searched some about 10 or 9 best papers. I mean, I would say, what is the best paper? What is the landmark paper? Now, there has to be certain salient points about this landmark paper publication, or seminal papers, as we say that. So let us see. I mean, a couple of two or three points as to what is a seminal paper in anything in neurosurgery. Let's say, for example, the seminal paper is the paper which changes the ideas of which changes the prevailing idea that is already going on in a particular scientific field. Number one, it is a game changer. This is what you call as a seminal paper. The number one prerequisite for being a seminal paper is. Number two prerequisite for being a seminal paper or a landmark paper is that it should be highly cited by your peers. It should be recognized by your peers. It should be accepted. And thirdly, which is very, very important for your scientific work to become an established work and followed by them. This means that they should cite your paper also. So these are the two particular prerequisites that any seminal paper or a landmark paper should have actually. And we in India are particularly very, very privileged that we have such speakers, we have such authors, we have such publishers, we have such scientific people, scientific bent of mind, and many of them are still right now in this webinar who have the capacity to do that, who have done that in the past and are still doing that. And I really, really congratulate them. We learn from them. They are our teachers, they are our inspirations. Dr. Chandrasekhar is sitting here. Many people are sitting here. Dr. Goyal has left. Dr. Sridhar is there. Wonderful. I mean, I will take you through their papers, and it's a wonderful thing to read their papers and to take inspiration from them after reading these papers. So my talk is specifically restricted to the spine section, as was told to me by Jayesh. So I will take one by one, two papers from each section: tumor, degenerative deformity, etc., etc. So talking about tumors, number one paper which I found was this, which was published in Lancet in 2005, and it was cited by 2,659 times. Authors have cited this paper, and this was about whether a direct decompressive surgical resection in the treatment of spinal cord compression caused by metastasis is beneficial or not. So this was a randomized multi-institutional non-blinded trial, and patients with metastatic compression, they were randomly assigned to either surgery followed by radiation or by radiotherapy alone. So the primary endpoint was the ability to walk, and nonetheless, see how powerful this study was, that this study had to be stopped after an interim analysis because the criteria of this predetermined early stopping rule was already met beforehand. So there was no doubt actually that surgery followed by radiation is definitely better than subjecting the patient to radiotherapy alone. So this was a table turner because many a times when you especially go into radiation conferences, radiation physicist conferences, radiation oncologist conferences, they specifically very, very hardly press upon the role of radiation in any metastatic cord compression. So this was one study, and it was a highly cited study, changed the scenario after this publication of this study. Many people start quoting that, and the practice changed very much after this. The second publication was this publication by the spinal surgery group, the Global Spine Surgery Group. This was a new classification system for the spinal instability in a neoplastic disease. Now, this was published in Spine in 2010, and see how many times this was cited by 1,261 times. Now, this citation is till I think 2020 or 2019, because I was not able to find the citation index after this year. Maybe now it must be having more than every paper which I quote here must be having more than 500 plus citations now. So this spinal instability score was a comprehensive classification system with the content validity which can guide the clinicians in identifying when the patients will require stabilization procedures to be added into their oncology surgery. So this was a very, very important classification with a very good reliability score. And this was a table that they gave. And this is a point-wise table. And what they said was that the patients will have the scores of 0 to 6. They have the stable spine, and there was no need to fix after doing the oncologic surgery. From 7 to 12, it was indeterminate, they can fix or not. And after 12, it is an unstable spine, and it always requires a fixation added to the oncologic procedure. So let's see what are the trauma papers related to the trauma in the spine. Now, we all know about this wonderful paper, which has been cited till now more than 4,000 times. And this was that magic trial, the magic steroid trial by Bracken et al., published in NEJM. It was a prospective, multicentric, placebo-controlled clinical trial between methylprednisolone, high-dose methylprednisolone, or naloxone in the treatment of ASCI. And we all know this. We have several times debated on this trial. And in this paper, it was a game changer study. I mean, I was talking about which was published in 90, and this is more than 30 years now that it has been several criticism of this paper after that, several post-hoc studies after that. It's been already in debate now. And in 2013, when they said this in 1990, that this dose of methylprednisolone invariably improves the neurologic recovery if it is given within the first 8 hours. Now, after this, several, especially after 2000, several trials have been published, several papers have been published, and after 2000, in 2013, especially, this study was completely, I would say, refuted, and this strong representation of these steroids of the methylprednisolone was no longer taken, and methylprednisolone in SCI was considered no longer as a standard. It was considered not more than an option. Now, let me be very clear about it. This is a 2013 study in which it considers a steroid to be an option only and to be treated under grave circumstances. Another paper which is worthy of being called as a seminal paper was this classification of thoracolumbar injuries, which was published in European Spine Journal in 94, and this was more than 30 years now, 35 years, and this was the basis of the AO classification by Major, and this classification, a slight modification of this classification by Alex Vaccaro et al. Group is now still being followed, and now since the inception of this mechanistic classification, the things changed. No doubt the classification before this also, several classification existed, but what this classification achieved was that this was a comprehensive classification, and every injury was defined alphanumerically or by a descriptive name. So there were the three, every one of us knows this. This was a set of three, A, B, C, depending on the mechanism of injury. A was a compressive injury, B was a distraction injury, C was a rotational or the torsional injury. And in each of these three injuries, further there were three patterns. And the severity of the injury kept on increasing from A to C. From A1 to C3, this is the most severe injury was the C3. So comparing between the different centers, between the different patients, between the patients with different fractures was made easy after the advent of this classification, and it revolutionized the way that the surgeons used to treat the fractures. So hence this was included by me as this. Now come over to the degenerative aspects. We all know about this famous sport trial in which which has been cited more than 2,000 times till now, maybe more than this. Now this was first published in General Bone Joint Surgery America, and there were 13 centers, and the surgical candidates were there from these 13 centers who had symptoms of degenerative spondylolisthesis with spinal stenosis, and they were enrolled in a randomized cohort or observational cohort, and the treatment consisted of either a standard decompressive laminectomy with or without fusion or usual non-operative care, and these were the primary outcome measures, like quality scales were there. So what did the authors conclude was the patients who were treated surgically for this degenerative spondylolisthesis, they maintained substantially greater pain relief and improvement in function for 4 years. So this was interim 4-year result trial of patients with these pathologies comparing surgery versus non-operative treatment, and the surgery was a clear-cut winner in this. Another trial, a part of this sport trial, was to compare the surgical versus non-surgical treatment for a lumbar disc herniation. So this study, the authors also concluded that the surgery for lumbar disc herniation, it achieved greater improvement than the non-operative group. So this was another trial. Another famous trial I would like to tell was the trial by Failings Group from Canada, and it was like our center, our institute also. When I was at All India Institute, Professor Kale, we also participated in this trial, and this was about efficacy and safety of surgical decompressive procedures in patients with CSM. And this was a prospective cohort study, and all the adult patients with the symptomatic CSM and MR evidence of spinal cord compression, and there were a total of 12 North American centers were included in the study, and there were 260 patients. And this concluded that the surgical decompression in these patients, it was associated with improvement in all functional disability related and QLI outcomes at 1 year follow-up. And so there was a place for surgical decompression in patients with CSM. Another landmark paper which has been quoted extensively cited, and we all know about this. We do this surgery still now without any modifications till now, and this surgery has stood the standard, has been the gold standard, has stood the test of time for the last almost 75 years. Is the treatment of ACDF. The treatment of the cervical disc by ACDF procedure, and this was a study, and how surprising it is. Actually, this was only 14 patients that Smith took, and these all 14 patients was his retrospective study. And before, he was the first one to publish this study in 58 and in 54 basically, and then after that Clover published in 59, and both of them. The reason I did not include Clover's paper into this presentation, although it deserved the merit, was only that Smith published it first before Clover. So this was a wonderful paper which changed the practice, paradigm change in the practice, and then still this has stood the test of time till date. So now come to the deformity. In deformity, none other than Atul Goyal, his landmark paper about the plate and screw fixation for AAD. Now see the number of citations. This is from his Scopus, 1200, and he was the first one to publish this in the scientific literature, the surgical techniques, in 1994. Now, this is a very important statement which I am making actually. This was published even before Harms. Harms published in 2000. And Professor Goyal published in 2002 after he has already published about 8 years back. So this is what the scientific literature is all about actually. And this paper has been cited by more than 1,500 authors worldwide. And this is a landmark paper, landmark study, atlantoaxial fixation using plate and screw method. Now, this has become a routinely done procedure worldwide, and every surgeon, every spine surgeon. Another paper now has been, most of the surgeons, they are already instituted into practice. Another paper about scoliosis, Lenke et al., they proposed a new classification of scoliosis over and above the King's classification, which was prevailing at that time. And Lenke, this new classification was this classification was considered to be much more reliable than the King's system, which was prevailing at that time. And this paper, needless to say, was also a game changer and cited by more than 2,500 other authors. Now, the last paper which I included was this by Rasuli, and this we all know also. And this is a wonderful paper, wonderful game-changing concept actually, which he gave. Pierre Rasuli is from France, and this author, along with the other authors, they gave a beautiful concept of spinopelvic sagittal balance about spondylolisthesis, and this they divided this listhesis into low grade, high grade, and low PI, high PI pelvic incidence. I mean, a balanced pelvis. First of all, gave the concept of balanced pelvis or a retroverted pelvis. Now, the beauty with this classification system was that with this classification, they can guide the surgeon about whether to reduce the high-grade spondy or not, number one, or whether to simply fix in situ or reduce first and then fix it and then do the fixation. So this was a wonderful paper which changed the concept of high-grade listhesis especially, and guiding the surgeons about whether to reduce it or not, or whether to fix it in situ, or whether to reduce the high-grade listhesis and then fix it. So this was about it. Now coming to our Indian author, Professor Goyal, needless to say, you can see his publications, 851 with 55,000 reads, 16,465 citations. His total H index is 62 out of 19,371 citations. And all the papers, most of it papers, they are game changers, they are thought-provoking, they are different from what already has been done, like the concept that he says that fixation alone without decompression in cervical stenosis, in lumbar stenosis, gave the concept of plate and screw fixation. Wonderful. I mean, this is the thing that changes the scenario, changes the scientific scenario the world over, and he's still, we have all listened to him in the first talk, he's still desperate to go ahead. My due regards, my immense respect to this great neurosurgeon who is showing his way and who is making us learn about writing about neurosurgery. And these all are his papers which are really, really, thought-provoking, inspiring, and wonderful to read. Thank you so much.
Thanks, Sumit. I think that was a good overview of some game-changing papers. I would like Apurva, Jayesh to comment. I am just wondering if we have now enough evidence or good papers on minimally invasive spine surgery. Has it been a game changer at all?
So the reason that I did not, there are many actually about the minimally invasive surgeries actually, but the reason is that minimally invasive papers, they have at the most started later than 2010 actually. So the number of citations, they are not so many so as to make it to the top 50 or top 10 actually. So I mean, there is no doubt minimally invasive spine surgery has absolutely revolutionized the spine surgery. But if you talk about the citation index, the citations are not so many high just because of this reason.
Sir, it was excellent overview. I have requested you out of our presentation, but it is really amazing. It will be always keep in YouTube from now onward. Thank you so much. Only you can do that. Thank you, sir.
Thanks. Who goes next? Professor Dugani or Professor Pandey?
Request to Dr. Dugani, sir.
Okay.
So very.
Thank you.
Yeah, Sumit, sir.
Dr. Chandrasekhar, please, if with your permission, can I leave, sir? Because I have to go for this yes, sir. Thank you so much, sir. Thank you, Jay.
Thanks.
Thank you, sir. Thank you.
Okay, everyone. Thank you.
Thank you, sir.
Is it okay? Can you see the screen?
Yeah.
Yes. Thank you.
In slide sorter view, you need to get it.
Yes, sir. Yes. Good afternoon, and thanks to Dr. Jayesh, Professor Ramani, and Dev Pujari sir for the excellent opportunity and sharing a different topic other than a routine academic presentations. So today I think I may be the last speaker or just one speaker before. I'll take you through a few of our experience in the use of social media today, what is playing in the role, its role in neurosurgery. Now, basically, what is this social media? Definition-wise, it's a forms of electronic communication through which users create online communities to share the information, ideas, personal messages, and their content. Now, what are these social medias today which are available to us? There are, I don't have to go into the details of this availability of the social medias. All of us are aware. For the first time, the social media was, the internet was initiated in 1970. Since then, the utility of internet has increased. And for the first time, we had in 1979 what called Usedirect, It was used for official administration on internet. 1995 came classmate.com to govern and monitor the schools and colleges and teachers. 1995, we had 6degrees.com, which started creating the websites, group messaging in the world. By 2000, we had myspace.com. It was initial stages of the social media, families, friends, and social sharing of the private people. Next came Orkut, 2004. Many of us senior people remember. It was the mother of the modern social media network. All these networks didn't stand the test of the time because of these were finances were not involved in it, money matters were not involved in it. They were just to share the things. Then came by 1998 the Google, and which changed the whole world as today we see and still continues to do so. And all these platforms are interlinked with the Google. Now, what's the strength of this social media in the world as we stand today? Believe me, today it can make a government or break a government. And simple fact that the 4 richest men in the world today are social media owners. That itself tells you the strength of this media. As of October 2024, there were 5.5 billion internet users worldwide. That makes 68% of the global population. Of this 5.52 billion, that's 64% of the population use social media. You can imagine the penetration of this. So what's the strength now? It enhances the connectivity across the globe, immediate access to news and information, educational resources, learning platforms, platforms for self-expression and creativity, and career opportunities and professional networking were the important things. Now, why social media in medicine? What is our interest in this? As the time goes on, we need to also change ourselves because of the simple fact, patient population factors. Second one, our own healthcare provider factors, medicine and education, how it helps. I'll just take you through. As I mentioned to you earlier, there is almost 68% of the global population uses internet. Of this, 64% of the population are social media users. So it means we also need to use social media to reach the masses in all over the world. Now, why people slowly started moving from the academic, peer-reviewed academic media to the social media is because of the rigid publishing criteria, taking a lot of time, contents, quality, and infrastructure were not uniform. So the rigid criteria made people to slowly move away from that. Next came the biases of the academic media, geographical bias, personal bias, language bias, institutional bias, private, public, corporate sectors involvement, and professional relations, interpersonal relations. They had a lot of influence on the publishing of this academic media. Slowly people started moving away from it. 2020 survey by WFNS showed 70, now I'll come to the neurosurgical issue only, I'll not involve other medical involvements. 78% of neurosurgeons believe social media has significantly enhanced their continuing medical education. 65% reported social media to follow academic journals, keep up with the developments in neurosurgery. 2021, Journal of Neurosurgery found 45% of neurosurgeons use social media professionally. American Association of Neurological Surgeons reported 250% increase in social media followers from 2017 to 2022. Social media has revolutionized neurosurgical education by offering a real-time knowledge and sharing platforms. An article by Ramirez in 2024, where the use of social media in middle and low socioeconomic groups, surveying 2,000 medical students, residents, and neurosurgeons, found that the platforms used were YouTube, highest extent, then the Facebook and Instagram and LinkedIn were used to use this to go ahead with the neurosurgical profession. Contents accessed where 67% surgical techniques, webinars in 57%, research papers were accessed 62% of the time through the social media. Type of resources used were interactive case discussions 70%, recorded lectures about 61%, and webinars, live webinars were 65%. The resources were used. Benefits expressed by them was almost 66% had access to global expertise, improvement in knowledge and sharing in 60%, and enhanced access to training resources, almost about 57%. So these are the benefits by this study, which was the social media was making on them. Now, after the COVID-19, the digital learning revolutionized completely, and many of the in-person conferences were transitioned to the virtual platforms, and increase was almost 300% post-COVID. Until today, we keep doing it, and today what we are doing is exactly the same, using the social media and interacting with each other. These are the various forums available on Facebook, on Instagram, Twitter, and YouTube. Each country, each group, each zone, each specialty have their own groups on Facebook and all these social media platforms. On Facebook alone, we have more than 1 lakh neurosurgeons, as I know, and more than 70 groups are available, where by sharing your material with one group, within no time, more than thousands and thousands of neurosurgeons can see it, they can talk to you, they can interact, they can comment, and they can suggest. For example, Neurosurgery Cocktail has almost 32,000 people, neurosurgeons all over the world. Neurosurgery Group has 30,000 neurosurgeons in this group, and International Microsurgery Club has 22,000 neurosurgeons. Endoscopic skull base has nearing 8,000 neurosurgeons. This is a 6 months old slide, what I'm showing you. Hybrid microscopic endoscopic skull base surgeons, there are about 6,000 members. We started using social media almost 15 years back. Started with the Facebook just to have a social contact with the friends and the relatives and sharing with our social events. But subsequently, we found that it can be used as the time went on to the newer applications and apps coming up. We can use it even for the professional sharing, learning this our material. YouTube, LinkedIn, and X are the ones which we keep using. We have now on the Facebook app, we have almost 3 groups. One already has 5,000 groups. It doesn't extend that. Second group again has 5,000. Third group we started, now we have nearing 2,000 friends on this, and it keeps growing more and more. This is what we do on the social media. We use only for the academic purposes and sharing the knowledge and interacting and discussing. We put a video on the social media, and instantaneously all over the world, more than about 75,000 our colleagues see that. They see, they learn, or they give their opinion, and they suggest us for the improvement to what they would do, how they would do, and what are the things for improvement. It's a great help to every one of us. 2011, we started our YouTube channel on our professional video sharing channel. Last about 13 years, we are more than 13,000 subscribers, 585 videos, and more than 33 lakh people have seen these videos all over the world and keep interacting. Simple example, this video we shared 12 years ago, and more than 54,000 people have seen this video. Either they learned from it or they interacted, and they make us learn much more better things. This video we shared 13 years ago. 238,000 people have seen this video all over the world. Students, colleagues, trainees, families, and they keep interacting with the comments every day with us. That helps us either to improve ourselves, improve our techniques, improve our treatment details. Not only our colleagues, our friends, and our own professional people, the families of the patients They keep interacting with us. They keep asking questions. They want to know someone in their family, someone in their friends, they had a similar problem, how it would go. That helps us to really improve ourselves along with the society. Education. So what are the benefits to the society? Quick services, knowledge dispersion, education of the society, information and interactions with the people, and what to us as a healthcare providers, sharing, interacting, learning, and improvising ourselves to achieve better and better. Friends, there is always red flags of this media. This is not a controlled media. Always, this itself is a big topic. I just touch the important points so as to make aware of the social media drawbacks or disadvantages, ethical and legal considerations, spread of misinformation, maintaining the patient confidentiality and privacy, cyber crimes. Now, of late, we are having AI manipulations in medical social media, which is going to be very detrimental, and one has to be very observant about it. Before you accept the social media platform, posts, analyze it, assess it, then accept it. This is what happens in the social media. What you see is not always right. So social media is reshaping global neurosurgery, offering unprecedented opportunities for education, collaboration, and advocacy. It provides a platform for continuous learning, bridging the global disparities, disseminating the critical information. However, as the neurosurgical community navigates through this digital frontiers, it is essential to remain vigilant about ethical challenges and promote responsible social media use. Social media can continue to play a very vital role in enhancing neurosurgical practice, learning, improving the patient outcomes worldwide, educating the communities and the societies, and which is going to be happening very in future. Thank you very much.
Thanks, Suresh.
Thank you, sir.
I think you have been a pioneer in using digital media to begin with.
Yes, sir.
Even in the days of, VHS and pneumatic videos, we were taking tips from you to make videos and stuff like that.
Yes.
But what I'm more concerned about, I think you have given emphasis on all the beneficial points of social media, which are education and advocacy, of course, apart from, I think, making people aware. I think the use of social media today is being blamed by, some hospitals or some groups or some individuals are being blamed for using it not only to promote themselves unethically, but also, proper evaluation of material does not exist. And the main conflict remains about we cannot, as an individual, advertise in any other media. But social media, there is still no legal binding that you cannot. And therefore, it is being misused to some extent. You have any comment on that?
Yes, sir. I very much agree with you. That's what I told in the red flags of the social media. See, it is uncontrolled media and nobody has a control over it. It's like an ocean. When we use it for our own requirements, we have to see whether it is right or wrong, analyze ourselves, and then you accept it. And see, as a responsible citizen from every profession for that matter, it becomes our duty and right to use integrated or the real what you want to do. That's why today, if you look at it all over the world, including our own country, so much of cyber crimes, so much of misuse of social media. See, last week itself, our government of India projected 1.6 billion rupees lost by misusing this social media. That's what it is. Ultimately, we are the professionals. We need to know our duties and our rights and use it accordingly.
No, but do you think the time has now come that we should have our social media manager as well to manage practice as well as to probably put the right perspective.
Sir, I'll tell you what, today, all the corporate hospitals in the country or in the world, every corporate hospital is on Facebook, it's on YouTube.
Hospital, yes. I'm talking of individual.
Personal.
Individual, yes, you can, sir. I think I'll tell you simple example. What I experienced in last 15 days or 15 years or 18 years using this social media. Initially, when we used to upload the videos on social media, there are a lot of what you call ethical and legal and data sharing of the people on the freely available social media. It was the biggest problem what we consulted the lawyers, we met them and we take their opinion, and ultimately we came to such an extent that we take all the people's consents and written consents. And now, believe me, sir, what is happening with me, I mean, our side people. Today, I operate one boy with a craniopharyngioma, and that boy has gone through my video channel. He's a college student or 8th standard, 9th standard student. Sir, I'll show you a few of his on YouTube, his comments on this. Sir, when are you going to put my video? Honestly speaking.
Anyway, I would like one of the younger members, Dr. Selvan, if you have any comments to make.
Simple, sir. One word. He has told it's an uncontrolled media. So we have to, if at all we want to play selfish, we have to make use of it till it is controlled. So in our place, we have seen even the government organized FM channel. Previously, the hospital advertisements were being announced. Now the individual new investment or new modality of management, everything is even announced in the FM radio itself. Nobody has bothered about ethical. It's about it's uncontrolled media. But we are living in that era. We have to face it. We have to mix with it.
Exactly. See, what is
happening? I think there seems to be a greater awareness. You must have seen 2 countries, one in Europe and Australia, have recently banned use of social media for people under 16 because those are different issues. I think we move on to the next and last and the most difficult. As you can see, that the topic itself is difficult. But it has become more difficult for neurosurgeons because our present example, we are already 150% more into our time. And if you have told our wife or our children that I'm going to take you out at 3:30, I think that's going to be very, very, very difficult. So Paritosh, you have all the answers. Let us hear.
In fact, Paritosh sir was very busy today and I have done a frequent request, and after that he was ready to do this. Thank you, Paritosh sir, and sorry, we wanted you to first, but you may not be there, so that's why.
No, the screen is visible, right?
Yes.
Yeah.
This should be kept the first talk of the next webinar, but we'll hear you.
No, sir, nothing like that. I'm not at all busy, but listening to webinars on a Sunday afternoon is not the best way to have a work-life balance.
To have work-life balance, agreed.
But still, whatever is to be done is to be done. Also, I will just say that I derive my pleasure out of work, and work is my primary sense of pleasure. So just because I'm advocating some work-life balance should not mean that I am like a very, very lazy person. In present times, work-life balance talk has become an anathema, and we have gone through this. In early 2000, the American system made a rule about 80-hour residency, and there were like hordes of paper. And still there is a lot of lament about this capping of 80 hours, that the residents are not as good as their generation. And a section of older generation will always feel that the younger generation is not as good or as dedicated, as hardworking as they are. And there is a deep disappointment among a section of older generation regarding younger folks who do not want to put similar efforts as they did. This is most exemplified by Mr. Narayan Murthy, who keeps on hammering the whole concept of 70-hour week. And then, of course, there are some other people as well who do that. And it came recently in a Wall Street Journal article where they said that the younger folks do not have the work ethic as they had. And that is what is there. I have absolutely nothing against hard work. I mean, I think hard work is great, and people who work should work very hard to justify their existence in this planet. But often people who practice this philosophy become very patronizing. They become an ideologue of a philosophy, like they become akin to communists or some other atheists, some kind of people. Like, this is the only philosophy that will work and no other philosophy will work. They become sort of moralizers, and they practice this whole thing with missionary zeal. And they're great people. They're very well accomplished people. But because one thing has worked for them, they think that that is the only path which can work on them. Sunil has mentioned Keynes, and Keynes in 1930s said that 100 years later, like 2020, we are 5 years away from it, people would work only 15 hours a week. His prediction was, because we have had so much we will have so much technological improvement that people will have to work only this much, 15 hours a week, and rest of the time they will devote to other things in life, like philosophy, music, plays, children, family, all kinds of stuff. And what do we have now? We still have those, we want to go behind, we want to regress from the 48-hour week that Henry Ford started long back, and we want to make it 70, 80, 100, 140. Fortunately, there are only X number of hours a week, otherwise these moralizers would do that. If you say to any neurosurgeon, I'm just doing this as a neurosurgical exercise, but it can apply to all over. If you say top 5 regrets while dying, is it that I could clip only 1,000 aneurysms? Is it that I never became the top doctor in my city, region, country? Is it that I did not publish many papers? None of them. Your life, you and your life are more important than your pursuits, and your pursuits are not your life. So the top 5 regrets of dying is: 1, they would have courage to live a life true to themselves. Second is, I wish I didn't work so hard. Third, express feelings, stayed in touch with friends. Happier. Now, if work makes you happy, and of course it makes everybody happy, I think it is a very, very important part of your whole life. But work-life balance says that, very simply, it is the realization that work does not encompass all your life. And there are other facets like family, self-attainment, travel, hobby, and most importantly, rest and relaxation. I implore you to read a book, Why We Sleep, by a very, very famous person. And it will show you all the benefits of what we sleep. And things like, I sleep only 3 hours a day, 4 hours a day, which are very, very loosely thrown around, and not realizing that there are people who will suffer the consequence of these loose comments. So all these factors are so important. And what we need to do, or at least I do, is that we have clear boundaries, we have time management, we have balanced social life, and we have reduced stress. So we have career, and that is one facet. We have our health and well-being, we have community, and then there is a home and life. So how do you achieve it? Anybody is replaceable. This is the first realization that we will have, we should have in our lives, at least when we turn to 40 or 45. If you unfortunately die tomorrow, you will be replaced in 1 second. Nobody will even think about it, what you were. And that is the realization that you are just a cog in the wheel. And as soon as you are not a cog in the wheel, you will be replaced by another cog in the wheel. Second is the realization that you should be in the race, yet get detached from the race. And because life is not a T20 match, it's like a test series with all the twists and turns, as we are seeing in Australia-India series. And the third most important thing is we must prioritize ourselves. We are seeing so many heart attacks, strokes, all kinds of events, diabetes, hypertension, rampant. Suicide rates in doctors are 3 times more than the average population. And why is this? Because people have not prioritized their own mental and physical health. And it is high time that we start doing it. There is another thing about working smart. There is very little correlation between working hours and efficiency. And a happy and relaxed mind works better and more efficiently. There was a company which did the whole working hours as only 9 to 1, during which people had to only work. No tea breaks, no social media breaks, nothing. 4-hour day. And that thing itself improved the efficiency by 200%. So this whole compulsory work hour is basically a trap by the whole thing. And if you work smart, you will realize that you can finish your work in very, very little time. You have to prioritize your family. Again, unfortunately, if you pass away, nobody, and I say nobody, will be affected but for your family. So have protected time for them. Develop a hobby to unwind. I have a hobby. I read a lot. I write a lot. I read all the time. And even though I don't write very well, I write every day. And you will see the most accomplished people in this whole planet are not the hardest worker ones. If hard work had become the norm and the way to become a billionaire, then the person who is working 2 shifts in the metro or a construction industry would be a billionaire. So hard work or hard working hours is not something that will lead to most of the things. So you must have all these work-life balances things. And so work hard, work smart, but also live other facets of life. I'm not a big fan of being a one-dimensional person, though I'm in awe of people who are kind or that kind and are completely devoted to their work life. But even they should not have a missionary zeal to convert the people who should want their rest and relaxation. As they say, you are here for only a short visit. Don't hurry, don't worry, and be sure to smell the flowers along the way. And with this, thank you very much.
Thanks, Paridosh. I think it was a brief but a very nice message. And you used some personal comments as well. That's a good thing. What I am going to ask you is that for a surgeon, I don't think 4 hours a day work is possible. There will be days when you will be working all day, maybe beyond 8 hours, 10 hours, whatever. There will be days when you may not have more than 2-3 hours work. So do you think this login and log out from the hospitals, etc., this system should be taken away? At least
absolutely.
For doctors?
I am completely taken. I think people should finish their work that they have been assigned. That is my philosophy. If I have 4 cases, I will work 16 hours. But if I have no cases,
I think especially surgical units should probably strive to, develop such a system that the hospital does not force people to, be in at 7 o'clock and be out at 5 o'clock kind of thing. That is one thing which I think we should all try probably, if not within our system. The second question I have is, developing hobby, etc., is entirely individual. But I think some of your comments are very important that we realize very late in life that, especially, I realized it during only COVID time that sleeping has its own benefit. If you slept for 7 hours, you are a different person the next day, rather than sleeping for 5 hours. But with people like Narayan Murthy and our Prime Minister, who not only takes pride, I think people talk about him in such glowing terms for taking very little sleep. It was the same with Jawaharlal Nehru. So I think probably the generation wise also there is a difference now. And physical work need not be equated as from what you are saying as to the effort put in into the work. Is that what I understand correctly?
Absolutely. I mean, I'm suggesting the book called Why We Sleep. I will send it to you. It's a great book, and it will show you why you must sleep at least 7 hours a day. And if you can, and if your hospital has a lounge, take a small siesta in the afternoon. It's a great thing. I do it all the time. I have lunch, I sleep for half an hour.
Most of us do it during conferences.
Don't get me wrong, sir. I'm not a lazy person.
No. I'm not.
I think it is very important for people to prioritize themselves and not just get into this whole business of having a clinic as well in the night and seeing patients till 10 o'clock in the night. I mean, and what are you doing?
A lot of things are depending on tradition where you work. But your point is well taken. I think I would like younger people to comment.
Sir, one line I like most is you should be in the race, but you should keep, detain yourself from the race. This is for us, for our generation, it's we always feel that, okay, if we are not in the line, then we may be out of that. So this is very important message what you have given. Amazing, and thank you so much, sir. Selvan, sir?
Yeah, I accept it. We have to be in the race, but the race cannot be done every day. We have to rest and take some rehearsals and come for the race. It's very well taken from sir. He has done a wonderful job.
Fine, sir. So thank you, Paritosh, sir. First of all, we'll like to end up our webinar here. Thank you, Dev Pujari, sir. Thank you, Selvan, sir, for your presence. Thank you, all the speaker, Dogani, sir, Dr. Paritosh, Dr. Sunil, for here to stay with us. Thank you enough, Mr. Vandan Patel from Osteopore, to help us to get all this thing in line for technical media. Thanks, Apurva and Rishabh, to help me to manage this webinar. Thank you, sir, and good day for Sunday and we'll visit. Thank you. Thank you, Depujari.
Thanks, everyone.
Thank you, everyone.
Happy Sunday to all.
Thank you.
And